Well, good morning, everyone. I want to welcome you to our 2021 Virtual Maternal and Child Health Symposium. We have a jam-packed symposium set for today. And my name is Kenesha Bryant Moore. I am the Assistant Dean for Diversity, Equity, and Inclusion at the Faye W. Bozeman College of Public Health at UAMS. And I'm also Associate Professor in our Department of Health Behavior and Health Education. So I am excited to be a part of this symposium today, and it is actually funded by a grant we have received from HRSA to increase our educational opportunities around maternal and child health within the College of Public Health. So it not only funds symposiums like this, but also student scholarships. So students who have an interest in maternal child health, we do offer scholarships for those students in our master's program. We also are offering new programming and courses. And so we have had our Motherhood Together program for a couple of years now. And that program is specifically designed to support women who are facing homelessness or housing insecurity within the Central Arkansas area while they're pregnant, and that getting them access to prenatal education. And so we've been working with that program for a couple of years, and the HRSA funding that we have received will actually continue to support that program for the next 4 years. So we're really excited about that as well. I'm actually going to go ahead and turn it over to Dr. Christy Caldwell. She is going to just share a little bit of information about the College of Public Health.
Good morning, Dr. Brian Moore, and good morning to all of the program participants and everyone attending today. So I'm actually thrilled to be here, and I got to thinking about, what a wonderful time for you all to have an MCH Symposium Mother's Day weekend. And so that kind of, got me really thinking about, as you all discuss all of the topics today, how fitting it is, because of course we know that the bond between mother and child is probably one of the greatest that exists. But I'm here today really just to talk about, why public health. The events over the last year have allowed public health to gain both attention and the recognition that it is always really deserved. Public health as a field is both sufficient and necessary as a field of science. It's things that we do every day, and we don't really necessarily think about them. So what does this encompass? It encompasses things such as this current COVID-19 pandemic that we've been dealing with for the last couple of years. It deals with social justice events that have transpired in our community, in our country, in our world recently. And it is essential to understand that public health is both rooted in social justice and demands quality health, justice, equity, and equality for all individuals and communities. So what are we looking for? We're looking for those individuals who wish to join the public health workforce. Public health promotes and protects the health of people and communities where they live, learn, work, and play. That's just about everything that we do every day. So while the majority of the healthcare clinicians and fields treat people who are sick and those who are already diseased or are dealing with injuries, we in public health want to try to promote wellness by encouraging healthy behaviors. Now, the College of Public Health does accept all majors and undergraduate degrees, so it doesn't matter what that degree is in. Sometimes we start off on our life journey on one path, and then we find out that our experiences and some of the things that we go through will lead us in another direction. Now, you will be required to have a bachelor's degree, but that degree can be in just about anything. So it'll be helpful to have some science, a little bit of math, but if you don't have those skills, we also have things in place in the school that can teach you those foundational skills that can accompany with the education that you already have to make you successful in public health. So a degree in public health at this time is a very highly valued commodity. And given our current situation with the pandemic that we're battling, it could provide longevity for your career for many, many years to come. So when you think about public health, I want you to think about public health is the foundation of all health careers. All health truly is public health. And so what we want to do is we want to provide you the opportunity to sign up to be part of the boots that are on the ground that are making the impacts in the communities and the lives of the population to make sure that we all have a better chance at life, health, and equality. So you don't have to necessarily just pursue a full master's degree in public health. We have several certificates that you also could pursue. So what I'd like to do today is I will make sure that I drop my information in the chat so that those who have been thinking about it, because there's going to be somebody that's in this conference today, someone on this call. Graduate school is one of those things that we either constantly talk ourselves into or out of every other week or every other month. But if you've been pondering that and you want to know a little bit more about it, I'd love to visit with you. So we here at the College of Public Health, we will continue to educate, inform, and empower and grow our public health workforce, both here in Arkansas and throughout the nation and the world. So last fall, we actually enrolled our largest incoming class of public health students in the history of the college. And I don't think that this trend is going to slow down, especially given everything that's going on around us. So I just want you all to know that there is a future in public health, for sure. And as we continually begin to define and adjust to what we've been calling for the last year our new normal, I like to call it our now normal. And it's always evolving. Public health is very fluid and dynamic, and there's always something new on the horizon. And we want to train you all to be the workforce that's prepared to handle not just this pandemic, but every other phenomenon that's going to come in the future. So I'd love to visit with you more about that, find out where you currently stand, what we can do to help you get educated and get your things in order to consider really pursuing a degree in public health. It's a wonderful degree. It's highly infectious to get passionate about. And so I want to thank Dr. Bryant Moore for this opportunity. And as I mentioned, I'm going to go ahead and drop my contact information in the chat. And I'd love to visit with anybody else that would love to become part of the difference that we're going to make in the future here in Arkansas and other places. Thank you.
Thank you so much, Dr. Caldwell. And I always had to put a plug in that, we also have our doctoral programs. And so anyone who's interested in pursuing a doctoral degree, a PhD specifically, and I would love to mentor you. I would love for you to be a part of some of the work that I'm doing. So also take that into consideration as well. And I'm also excited because we have taught our first intro to maternal child health course as part of this grant this semester. And we have 2 of our students actually here being a part of the symposium as moderators. And I want to make sure that people not only can see what's going on, but actually be a part of it. So as they, get their degrees, graduate and become those public health practitioners, they'll already have that experience of putting on symposiums and working with our community partners, which is just awesome to me. So that being said, when we will introduce our speakers, and during our Q&A session throughout the symposium, just for the sake of time, we're asking if you have any questions, just to drop those into the chat box. And then our moderators will then read those questions for our speakers. And that's just to save a little bit of time so we can get as many questions answered as possible. So as our speakers come, feel free to drop these different questions that you may have, or even comments into the chat box. And our moderators will then read those questions for our speakers. And I did not forget, if you were one of the first 100 people to sign up, you will be getting a swag bag. So, I love giving away stuff, and if we could come together, I like to eat and I love to serve food. So I'm looking forward to hopefully 2022, we can all come together and we can have a meal and get some swag as well. But I always had to put a disclaimer, please give us 4 to 6 weeks for shipping and handling processing. But I guarantee you will be getting your swag if you were one of the first 100 to register for the symposium. And so I'm going to go ahead and turn this over to our moderator for our first speaker. So Blessing, if you want to go ahead and introduce our first speaker, I will turn it over to you now.
Hello, everyone, and welcome to today's event. Good morning. It's an honor that you all are able to join us, and we are very happy to have you here. I'd like to introduce our first guest speaker, Mrs. Janae Harris, who is going to be speaking to us about period supplies. Mrs. Harris was born and raised in Chicago, Illinois. She relocated to Pine Bluff, Arkansas for college and obtained a bachelor's in criminal justice from the University of Arkansas, Pine Bluff. Mrs. Harris holds a certificate in anti-racism from the Diversity and Resiliency Institute of El Paso and a certificate of diversity and inclusion from Cornell University. She holds professional memberships in several different organizations, such as the Sigma Gamma Rho Sorority Inc., and she's a proud and active member of the Junior League of Little Rock. She's currently pursuing a master's degree from Cornell in applied economics and business. She has been married to her husband, Michael Harris, for the last 12 years, and together they have a son, Kai. Mrs. Harris focuses on bringing awareness to period poverty across the state of Arkansas. And she's the founder of More Chances Period, which provides free period supplies to girls and women in underserved communities across Central Arkansas. She's also actively involved in initiatives that promote racial, cultural diversity, and inclusion awareness. Thank you, Mrs. Harris. Over to you, please.
Thank you so much, Blessing, for that introduction. You did a great job. Good morning, everyone. Again, my name is Janai Harris. I'm very excited to be here and be a speaker. And let me apologize in advance. My voice is a little up and down. My son had a tennis match on yesterday, so you moms know how it goes. So my voice is going in and out a little bit. So today what I'll be discussing is period poverty. A lot of times people think that they don't recognize that periods are things that happen, regardless of a pandemic that we're currently going through, regardless of any given situation, regardless of anything, periods are just gonna happen. And it's been like that forever since the beginning of time. And so a lot of times focus is more so on providing, of course, Arkansas has an issue with food insecurity. People never actually realize that there is also an insecurity of period supplies. I mean, you would never think anything like that, but it affects Arkansas, and it affects Arkansas in a really big way. So I'll go into my presentation. I didn't create any slides. I'll just talk from my experience here. So you asked, what is period poverty? It is basically the inability to be able to have access to sanitary items due to cultural, social, financial circumstances. And often with not having access to period supplies, it becomes a burden, a big burden to those who are experiencing the period poverty. And just to put it in layman's terms, basically, you got $5 and you have to make the choice between buying a bag of pads or buying food for your family. That's period poverty. I mean, I can't get it any simpler than that. And I'll just present with a couple of facts here. Most 7-day periods cost about $14 to have a 7-day period. So the cost is about $14. And then if you have a 3-day period, it's about $6. And we do know that normally cycles are between a 3 and 7-day period, 3 and 7-day cycle. And so you're anywhere between $6 and $14. So if you're already suffering from having food insecurity or being in that underserved community, then you're having to make tough decisions of buying food or period supplies for you or your dependents. Women spend around $7,000, and I was so astounded. I couldn't even believe when I was doing the research. They normally spend about $7,000 on period supplies for their lifetime. So over your lifetime, you spend about $7,000. And when you think about that, you're like, geez, that's enough for a down payment on a home, put your kid through private school if you choose to put them in private school, or just necessities that you'll need in life. So that's a big amount to me, $7,000. The average cost of a box of tampons is $5.99 plus tax. An average cost of a bag of pads is $4.49 plus tax. And actually, a few weeks ago, I was out doing some shopping for the organization. Had received a donation from a donor, and was out doing some shopping. And so once I got done shopping, I sent her, of course, a thank you text, thanking her so much for her donation, and I sent her a copy of the receipt. And I was like, we were able to buy 15 bags of, period supplies. And we kind of conversed back and forth about that. And she said, hey, Janai, she said, look, she said, did you realize the actual tax that's on these period supplies? And I'm like, let me look. And so I looked, and it was literally enough to buy about, between the tax on all 15 bags, we could have put all of that money together and bought about another 4 or 5 bags of pads just off the tax. So not only the cost, but then also because it has the luxury tax on it, which to me, tampons and pads are not a luxury item. It's a necessity. We need it as women. Also, 33% of girls and women struggle to afford menstrual products for themselves and their dependents, like I said earlier. And our chances, what we basically do is there's no criteria for or form for anyone to. What we do is, if you're in need of period supplies, we give them to you, regardless of your background, regardless of your race, your sexual orientation, any of that. We are an absolutely no questions asked organization. You come to us with a need and we supply your need, and whatever that need may be as far as pads and tampons. And so we definitely try to strive to make sure that we do that. We also make sure that we provide the supplies for underserved communities. And when I say underserved communities, we're talking about communities who are right there on that poverty level, and then also communities who are in the rural areas, because the rural areas have a lot of insecurities that a lot of people don't know about because it's out in the rural. I know the whole big fuss has been about the broadband. It's not having access to the internet, but they also, the kids don't have access to basic necessities. And it goes with women, girls, and whoever else may need the pads. They don't have access to it. They have to spend money to drive to town to buy them. By the time they get to town to buy them, then they spent gas money that they could have put towards the actual bag of pads or the tampons. And so that's taken away from what they can actually afford. And if they're already having, financial issues going on, then that cuts down even deeper and harder. And, no one should have to make a decision to buy food or to buy a bag of pads. I just feel like that is absolutely ridiculous in the United States of America. We should not be going through this in 2021. And so that's why my organization was brought about. We was created late last year, we created the organization to be able to serve the community. And just from taking the stats from March, actually, I'll go back, February, March, and April, we gave out over 12,000 pads and tampons to over 1,000 women and girls right here in Arkansas. And that's not even covering all the areas. We had some to go up to Fayetteville. We had some to go down to Southeast Arkansas, and some on some college campuses. So, it's definitely, when I look at that number and I'm saying, hey, this is only for 3 months and we're one organization giving out over 12,000 pads and tampons, it's definitely a problem and it has to be addressed. Only 4% of local women know of where they can get free or reduced cost period supplies because no one talks about it. No one puts it out there. You always see the food banks. You always see, if you need assistance on your lights, your gas, different things like that. But you never just see a flyer about, hey, if you're in need of personal female hygiene products, you can contact this organization. We're a no questions asked organization. Some organizations require that you may be homeless or living in a shelter. We don't require that. We don't care if you have a home, because just because you have a home does not mean that you're not going through a struggle or that you're not facing, period poverty. It happens regardless of your social status or whatever. You may still need it. You don't have to be homeless. Also, we noticed too, a lot of young ladies and women, mainly with our research, high school, middle school and high school girls, it can become kind of embarrassing a little bit. Let's just say, you're in the middle of third period and you get your period. You may not be prepared, your first time getting your period. I was one of those girls. First time getting your period, and you're in the middle of your third period class and you don't have a pad, you don't have a tampon. So what do? You're too ashamed to go to a friend. You definitely don't want to go to a school administrator to ask for, a pad of tampon. And then a lot of times they don't even have them to give to you. Some schools have them, some schools don't. It's just kind of like a toss up there. But a lot of girls, they, even with having a period and knowing that they're gonna have the period, they don't have the supplies. It's not they don't think that they need it. They just, their mom or their dad can't afford to make sure that they have it for when the time does happen, because they can't afford to buy things that they just don't need right now. And so that's often an issue. And even with the issue of them not having the things, with them having a period, a lot of girls and women will use makeshift items such as newspaper, which we all know newspaper has germs, cotton swabs, socks, torn up old underwear, old rags, tissue, even makeup pads. So that's definitely something that no one should have to do, is use a makeshift period item. Number one, it's unsanitary. Number two, it does not serve the purpose that you need it to serve the purpose, because it's a makeshift item. So, you're still going to be having, spills, or you're still going to be having, soiling your clothes. And that can be quite embarrassing in school. And with that happening while in school, that hurts a girl's self-esteem. It hurts the different activities that they may want to participate in, because they're too ashamed, because, they may have had an accident at school and everyone remembers, oh, that's the girl who started her period in third period and didn't have a pad. So a lot of times, when girls don't have access to their period supplies, they stay home. They stay home from school. And we all know staying home from school is a missed opportunity for learning and education. And what that does is that puts them, even if they're already having a struggle in school with learning or just being, on task and being on top of things. If you're missing 3 and 4 days a month, that's very much a missed learning opportunity. Within that time frame, you can have a test that you've missed and have to make up. You can have homework, you can have review sessions, and just overall at that time, in going through middle school was a very tough time for me, because I'm of the very short stature. I'm very short. And so I always, I won't say bully, but teased about being so short, but my whole entire family is short. And I think I go back and think about the fact that, what if I had suffered, period insecurity at school and got my period? I would have that on top of being teased for what I was already being teased for. So it hurts a girl's self-esteem when they don't have the items that they need. It makes them feel like, they're less of their peers, and they don't view themselves as equal to their peers. So a lot of times it hurts the fact that they even want to work in school, because they feel inferior to their peers, because they know that they're not going through this, and they feel like they're the only ones going through this, and they're going through it alone. And a lot of times the parents are too ashamed to let the school know, hey, I don't have the money for the pass, or the, so that's why she's not coming to school. A lot of times they just miss, and don't, there's no explanation, oh, they were out sick, when in actuality they're out because they have their period. Which for me, my parents were able to provide certain things for me, include, of course, period supplies, but it's a simple thing of going in the closet and grabbing a pad out when I was growing up. But it's not that simple for a lot of girls right here in Arkansas. We talk about, out of the country, and we talk about different states, but it's happening right here in our backyard. It's happening right here. It's happening all over the city, West Little Rock, Sherwood, it's happening everywhere. You name a city, I pretty much have delivered period supplies to a school or someone in that area. So it's not oh, this only happens in certain areas. That's not how this works. That's not how period probably works. It does not discriminate. Currently, there's 30 states that views period supplies, I touched on a little bit earlier, period supplies as a luxury, and they impose a luxury sales tax. For whatever reason, why it's considered a luxury, I don't have a clue, but they impose a sales tax on it, luxury sales tax on it. Right now, there was a bill, House Bill 1611. It did pass the Senate and the House. And in that House Bill 1611, it basically stated that if the school can actually use school funding, because we all know how school funding works. It's a very cut and dry line, and you have to use those funds for what it says, or you'll be in some big trouble. But now actually it's heading to the governor's desk. I'm not sure if he signed it yet, but it did pass, where the school can actually use funding to provide free period supplies for girls or whoever may need it in school. And so that should be, I'm not sure if he signed it. At last I checked, it hadn't been signed yet, but that is something definitely coming through, and everybody's so very thankful for Representative Denise in it. She was instrumental in getting that done and getting that presented. So we are very, very grateful for her and all her hard work. But also it goes back to the fact, even given the fact that now, okay, hey, we've opened up the door where you can actually use this funding to buy period supplies, we have to go back and we have to ask ourselves, will this funds be actually used to buy the period supplies? Because it's up to the school. It's not mandated or saying that they have to actually provide it. It's just stating that, it's optional, that now they can use the funds to provide those types of things. So if you have a school that's in need of, let's just say, new, say they need renovations on the bathroom and they need to use funding for that, more than likely that funding is going to go towards that renovation for the school, opposed to going out and buying a whole stock of period supplies. So, that's still something that's kind of, it's, we have the money, but are we actually going to be able to use it for things? Because we all know schools need different things for their students. And so a lot of the funding has to be used for those things that they already have lined out. And this will be something new. This will be the first year, upcoming term school year, that they'll actually be able to do that. So we'll have to watch that to see how it goes, and if it's actually effective, because of course, the leftovers is probably what mainly of the schools are going to be able to use to buy the period supplies. And as we're discussing, the House Bill 1611, just recently, Scotland, the country Scotland, was first in the world to make period supplies free to everyone. So, that's a win for Scotland, but we got to come here and do something far as being period supplies. And the thing is, it's not even a thing of necessarily saying, okay, we want free period supplies. Yes, in a utopia world, we absolutely would love for everyone to have access to free period supplies. But we know right now that's simply not possible. And really, the luxury tax is what, everyone is fighting to get removed from, because as stated previously, you buy 2 bags of pads, between the tax of those 2 bags of pads, you could have bought another bag and have, 3 or 4 months supply of them. And so we're, that's the thing, the luxury tax, we're just, the luxury tax has to go, like, seriously. And also took a poll in Arkansas. 92% of the people in Arkansas believe that period supplies should be tax-free. This is men and women, not just women, but men and women believe that they should be tax-free because of it's a necessity. So, you got the backing for it, and everyone believes that. But, it's just a thing of making it happen. And I know there is rules and regulations with the taxation and the revenue committees and all those things that go into our wonderful budget for the state. So we definitely do understand and know that, that takes time. It's not something that happens overnight. And not only with the makeshift products, 1 in 4 last year struggled to purchase period supplies. 1 in 4 people struggled to purchase period supplies. So we're not just talking about middle school girls here. We're not talking about high school. We're not talking about just college girls. We're talking about women who are employed. We are talking about women who are employed full time, who can't actually afford the period supplies. And we actually have to, do something about it, because you're working a full-time job and you're still struggling to actually buy pads for you and your dependents. I always go back to the story, and I tell people the story about my brother. My brother has 7 kids, 6 girls, 1 boy. So imagine what his bill is for period supplies. You got a 13, you got a 16, and a 14. Then you have my sister-in-law. So, that's a hefty bill. Well, guess what? That's just for right now. He has 3 younger daughters that are coming up. So eventually he's going to be paying for their period supplies. And with that being said, if I'm talking $7,000 on one woman, multiply that times 6 in a lifetime. And just while they're young, because as we know, with times changing and things like that, girls are getting their periods a lot earlier than what myself or my mom or my sister may have gotten them. There was a young lady, she was 4th grade with a cycle. So, it's coming younger and younger. Also, 1 in 4 teens, they actually miss like being involved in extracurricular activities such as basketball, cheerleading, or, just hanging out with friends, being a teenager. We've all been a teenager. We know we'd like to hang out with, our friends and things like that. And so, they miss those activities because they're ashamed, because they don't have those supplies, or they may only have a supply for 1 or 2 days. And then it's the thing of educating them on making sure that you're changing, your sanitary napkin like you should be. And a lot of them say, well, we don't do that because I don't have enough to change them. And it just breaks your heart when you hear that. And, it's just really rough. Like I say, it's really rough on kids, especially when you're in middle school, high school, you're building yourself. You're building your character. You're building, your confidence in yourself. So if you lose that along the way in middle school or high school, it's really, really hard to get it back in college. And some people just never get it back. Talk to several ladies, grown women, my age, older, who said, they had a traumatic experience with, their cycle or getting their cycle in the middle school. And it really just did something to them deep down inside. And now they're not as confident as they were in themselves back before that situation happened. So, we definitely, it's not just it only happens to middle school, high school. It happens to everyone. Everyone, like I say, period poverty does not discriminate. It happens to everyone. And like we said, this is something that's happening right here in our backyard in Arkansas. We do the food drives, we do the periods, we do the food drives, we do the different assistance for different things, but a lot of times, a lot of people don't know that there are organizations like myself out there that are willing to give, the period supplies to you for free with no questions asked, no strings attached. You don't have to fill out a form. I don't care, where you live, or none of that matters, because it's already a sensitive topic and sensitive issue. So we just try to do what we can to make sure that everyone has access to period supplies. And we strive to make sure that we are wherever we're needed. Last week we went to a vaccine clinic over in Southwest Little Rock that Director Adcock hosted, and we passed our bags of period supplies. And those ladies, you would think that you were giving out money, like $100, and I'm like, no, they're just period supplies. And one lady even hugged me so tight, and there was we couldn't understand each other because of the language barrier, but she was very gracious. She hugged me and everything. I'm like, oh my gosh, it kind of made me, I'm not going to say sad, but it made me realize, how fortunate sometimes people don't realize that they are, and myself included. You just don't realize things like that. And it was just a simple bag of period supplies. And I mean, she's very, very gracious. Everything. So definitely, period supplies is something that I feel like when um, I feel like that we need to take for granted, and that we need to make sure that we're not taking for granted, and that we are actually moving the needle forward on making sure that our young ladies have what they need in regards to, educate. We have to educate them first of all, and then not only educate them, because honestly, a lot of them don't know how to use a tampon. They know what they are, but they don't know how to use them. So if they don't know how to use them, then that can be another issue health wise. But definitely, it's something that we need to focus on when we're at these food banks. I feel like that we definitely need to focus um, on making sure that everyone have. I'm pretty much done with my presentation. If anyone have any questions, go for it.
Blessing, you're on mute.
Oh, I apologize. I have been rambling away. Sorry about that. Thank you so much, Mrs. Janae, for that wonderful presentation. I remember the first time that I heard about period taxes and pink taxes and lottery taxes. I hope moving forward something can definitely be done about it. So please, everyone, if you have any questions, concerns, just go ahead and put it in the chat box and I will send it to Mrs. Janae.
I see one where it says, thank you, Janai. How can someone donate? I actually have my contact number. I don't mind giving it out. I'm open and free for anyone to have it. You can contact me, code 70937-5137. I also have an email address. It's my name, Janai, Janai, Taylor, Taylor, Harris, at hotmail.com. Email me, text me, call me. I'm available.
Okay, so one of the questions that we got was, do you partner with other organizations that provide education about puberty and period to provide these supplies? And if yes, how do you find people, how do you find people out, or how do you find people to go about these services?
Actually, we have quite a few partnerships. We have a partnership with PATH. They handle like the sex trafficking victims and things like that. So we definitely do provide partnership, but then also we go into the schools, and when we go into the schools and provide the donations, we have a small little pamphlet that we hand out about puberty and period knowledge. Like I said, about the fact of needing to make sure that you're changing it as often as recommended. So we do definitely do that.
Okay. And then someone else wanted to know, how do people find out about your services?
Okay, so we do have a Facebook page. It is called More Chances Period. Just like the name of the organization is called More Chances Period. It's a public Facebook page. We can receive messages. We can communicate with you. We post pretty frequent on there. I do have a social media director who checks the messages. As soon as it comes through, she's responding. So, or forwarding to me if she can't respond for me. But definitely, if you want to go to More Chances Period on Facebook and follow the page and keep up with us, I can that's how you contact me, through my phone number, email, or through that Facebook page. We're whenever you need to.
Okay.
Just like that.
Okay. Mrs. Janae, if you don't mind, can you send us the number and contact information? A lot of people are saying they didn't catch the numbers. And they missed a lot of that. We have another question about it says, is the luxury tax an additional tax on top of the normal sales tax, Or does the phrase luxury tax mean that feminine products are not eligible for exemption
That's
from the
exactly what,
normal Arkansas sales tax?
that's exactly what it means. It's not eligible for exemption from the normal Arkansas sales tax. That's exactly what it means.
Okay. Another question is, has there been any discussion about doing a drive for menstrual cups instead of tampons and pads so that they have a more long-term solution? And then can we donate menstrual cups?
Yes, actually, we did do a drive. We partnered with the Biden-Harris administration for their Day of Giving, and we did a drive-through where people dropped off cups and different things. Like, of course, we wanted menstrual cups, but we collected anything that anyone would want to donate, mostly menstrual cups, but pads and tampons was included. And we did their day of service, and we was one of the only organizations. It was 3 organizations from Arkansas, and More Chances Period was selected to partner with President Biden and Vice President Harris on their day of service. So we had a really successful drive-through for menstrual cups. But I'll go ahead and I'll put all my information in the chat just in case. I know sometimes I talk fast. It's my city coming out of me. And so I'll put everything in the chat, my contact number, my email address, and everything. And I'm just so appreciative that you guys are all here and willing to listen to my stats about period poverty.
Okay, people want to know how they can donate, how they can connect other people to your services. So I think, the information when you send it, it's going to help.
Okay, absolutely. Thank you so much, Blessing.
Thank you. Thank you for coming. Thank you. Does anyone have any other questions?
Nobody seems to have any more, but we still have a little bit more time if people want to add them to the chat. And I since I am like hosting this, I'm just going to ask my question. So, you made the comment about women or young girls rather, like in junior high school or high school, having their first cycle and not being prepared. And I've seen like advertisements for these little packs that include like a pad, but also like a pair of panties and some like leggings, some black leggings, so if they have to switch clothes. And it's like something that they were selling, marketing. It costs more than me just putting it together myself. But I was wondering if that is something that you all have considered doing as well.
That's actually, and I apologize, I didn't speak on we provide period packies, not packages, but packies. And in that period packy, what we provide is we provide enough pads, tampons, and there's often menstrual cups in there for at least a 7-day period. I know sometimes females have issues, and so their period may be a little bit longer. We also provide a pair of underwear. We provide the wipes, the Summer's Eve wipes. We provide those in there. We provide panty liners for those light days where you don't actually need a pad. And then we also provide, it comes in a bag and it's smell proof. So if you're needing to toss, like you had an accident or something like that, it's a very discreet bag that you throw in your purse. No one can see what's on the inside of it. And so if you have an accident, with you getting your new pair of panties, we go ahead and you can discard the old ones in that period bag that we provide and throw it away and trash it. We don't, and that's a good question, Dr. Moore. Yes, I see a lot of people selling them opposed to giving them away. And I just think that is utterly ridiculous, because if they could afford to buy those, then they could just go out and buy a bag of pads. So that's why it's our mission to provide those types of things for free. There's no charge with anything that we give you. And I've had several people tell me that we give better bags than a lot of organizations that's a lot bigger than us.
Okay, and someone wanted to know, how do we implement this in other states? How do we create awareness in other states? I know states like Maryland and California have removed their luxury tax or pink taxes. So how do we create awareness in Arkansas? Like, is there something we can do about this?
Well, there are several, there's several organizations that actually do kind of work with it. And like I say, some schools have the products for them. It's just a hit or miss. We don't know which schools have them. We don't know which schools don't. We don't know when supply is up. We don't know when supply is down. So that's why I seen a need for it. And I'll be honest, how to create it, I just seen a need for it. And I was like, we definitely have to do something about this. It does not just affect homeless women; it affects everyone. So, people who have, like I said earlier, people who have jobs, they're still on that poverty line. We actually have a partnership with about 9 different organizations here in Little Rock and surroundings in the states surrounding, from Southeast all the way up to Fayetteville. And so we try to partner with the organizations. They help us with our marketing, as far as getting our, hey, this organization is here to help you, along with providing the supplies to that organization. We have several churches around here, again, like PATH. We are the official sponsor for the Dunbar Garden Little Free Pantry. We are their official sponsor for period supplies. So we rely a lot on not only just word of mouth, but also our partners, which have done an absolutely fabulous job of getting our services out there and people connecting people to us. That's why I was so astounded. I couldn't believe the numbers when I was going back reviewing and doing the stats for today. I'm like, geez, I didn't realize we had gave out that over 12,000 pads and tampons in 3 months to almost 2,000 people. But it's a blessing. It's truly a blessing to be able to do something like that and know that you are truly helping those in need. Like I say, our organization does not require, we don't need any stats from you. We don't need any, where do you live? How many people in the household? What's your income? We don't ask any of those questions.
Okay, and some people still want to donate. So when you send your info, I'm going to
Okay, yes,
it to everyone. So
okay,
that just
yes,
made me happy to read. Thank you, everyone. Some people really want to know how they can donate.
okay. I'm putting my phone number in the chat, and I'm also putting my email in there. And I see the link for my page has been dropped in there already. So definitely, I just sent over. Let me send it to everyone. My contact number and my email address. I'm available 24/7, 7 days a week. I work from home. I'm available.
Well,
Thank you.
oh yes, thank you both. So for those who missed that, joined us a little bit late, this was Miss Janai Harris that was talking about her work with More Chances, period. And we had Blessing, who was moderating, who is one of our students at the UMS College of Public Health. So I just want to thank both of you for just being with us today. I also want to put a plug in that for anybody who's a part of a community organization and you're interested in having one of our students do a practicum site with you or do their practicum experience with you, please let me know. Because that is part of what we do as well, is wanting our students to have the opportunity to learn about what's going on in the community while they're building their skill set, but also to support the work that you all are doing. So if More Chances, period, needs a student intern, please let us know and we can figure out how to partner together moving forward. We are actually going to be moving into our break a little bit early, but make sure you come back at 11:15. We will have Dr. Charlotte Smith, who's one of my favorite people and who is also an alum of UAMS College of Public Health as well. So please stay tuned and we'll see you at 11:15. Thanks. Well, welcome back, everyone. It is 11:15, so we're going to get started. Um, our next presenter is Dr. Charlotte Smith, and our moderator for this session is Sydney Rover, who's also a COPH student, and she's getting her master's in public health, but she's also a College of Medicine student. So she is one of our dual degree students here that we're excited to have a part of this program. So I am going to turn it over to Sydney.
Hi guys, so I'm here to introduce Dr. Charlotte Smith, who completed her PhD in Health Systems and Services Research with a concentration in Health Economics from the University of Arkansas for Medical Sciences in 2013. Charlotte is a health services and systems researcher whose primary focus concerns strategies for organizing and financing public health services, infant mortality, program and partnership development, and community health education. She has experience manipulating large data sets and performing descriptive, cross-sectional, and longitudinal data analysis using SAS and Stata, and conducting social network analysis. In addition, she has over 4 years of experience in clinical research. Dr. Smith is also interested in understanding why some public health systems have better than expected maternal and infant outcomes compared to their peers, and how to compare peer-to-peer sharing. Dr. Smith has experience teaching public health law, introduction to public health, and introduction to health policy and politics and epidemiology. She advises students and has served as a faculty member on the master's level research projects. So without further ado, Dr. Charlotte Smith.
Greetings, everyone. It's so amazing to see all of my Arkansas past colleagues and friends. And thank you, Dr. Bryant, for this opportunity. I'm going to share my slides and just give me a thumbs up if you are able to see them. Okay, thank you. How amazing. Well, I am grateful to be here today. Today, I'm going to talk about the Kansas Birth Equity Network, an initiative that we have started in the state of Kansas. And our idea, our concept behind this is just combating disparities in maternal and infant health. But before I begin to have the conversation about the Kansas Birth Equity Network, I want to tell you the why, because the why is a very important component of why we do this work. I want you to meet a few individuals during this discussion. First, meet Serena Williams. Serena Williams is one of the most famous athletes in this world. And so we know who Serena Williams is. With all of her power, all of her financial backing, and all of her known interests across this country, she still had to advocate for her life shortly after giving birth to her beautiful daughter. The nurse thought that her pain might be making her confused. But instead, Serena continued to advocate for a CT scan. When they finally conducted that CT scan, they found several small blood clots settled in her lungs. And Serena mentioned, she was like, listen to Dr. Williams. Why? Because we need to listen to the women. Meet Dr. Shanice Wallace. Dr. Shanice Wallace was a fourth-year pediatric chief resident. She died in October 2020 of pregnancy complications, just last year. Meet Dr. Shalon Irvin. Dr. Shalon Irvin was a lieutenant commander for the U.S. Public Health Services and epidemiologist for the CDC. She earned 2 master's degrees and a double PhD. The only goal left for her to achieve was to have a baby. She gave birth to a beautiful baby girl, but shortly after, she went to the doctor. She went to the ER 3 times. On a 3rd visit, her last attempt to seek care, a nurse practitioner sent her home and said, there is nothing we can do. You just have to give it time. Well, Dr. Shalon Irvin got 5 more hours that day and 4 days on life support. She also lost her life to pregnancy complications. What do we know about women's reproductive history and how that has influenced what we do today, or why we do this work, or what we're seeing every day in these disparities? We know that Black women's bodies were used to increase productivity and economic gain during times of slavery. We also know that there has been racism in obstetric and gynecology care, and it started with Dr. John Marion Sims, whose statue was just removed in 2017 in New York. And Dr. Sims did experiments on Black bodies with no anesthesia to standardize the evidence-based care for cesarean deliveries. We also know that Black women struggle with chronic stress, and a lot of this is proven in the hysterectomy disparities. By the age of 35, Black women are also 2 to 3 times more likely to have their uterus removed. And this is peaked at ages 18 and 24. And these are due often to fibroid complications, and those are often associated with chronic stress. We also know that Black women's reproductive health and all women's reproductive health is controlled by the political gains on women's rights and their bodies' reproductive injustices. In Kansas, the disparities are startling. For over 30 years, Black infants have been dying at 2 to 3 times that of white infants. And the reality is that we know that we have to focus on the mother's health if we want to improve the deaths of the infants. Most of these infants die within the first 28 days. Now, Black women are 2 to 3 times more likely to die in the state of Kansas than white women of pregnancy-related complications. We look at the disparities on the United States level, we see that the rates for maternal mortality are worse than they were 15 years before the end of slavery. 15 years before we had medical care, 15 years before we had health insurance, 15 years before we had hospital deliveries, 15 years before we had workforce laws. This is what we see. And yes, the records in slavery time are very accurate because slave owners kept them because it was a loss of productivity. When I look at the Arkansas data, it's surprising to see that the maternal mortality rates are startling in Arkansas. Arkansas's maternal death rate is the 5th highest in the nation with 44.5 maternal deaths per 1,000 live births. We still see the disparity between Black and white maternal mortality in Arkansas. What we know about these deaths is that we know that about 3 in 5 pregnancy-related deaths could be prevented. We know that these deaths are most likely associated with heart disease and stroke, cause more than 1 in 3 deaths. And let me just break this down. When we talk about stroke and heart disease, we tie that back to what we're seeing most often is that women are dying of pregnancy-related hypertension, complications with high blood pressure. This starts with pregnancy-related hypertension, leads to early onset preeclampsia, which leads to preeclampsia, which is classified as blood pressure, and leads to eclampsia. Hypertension, according to ACOG, is treated with 81 milligrams of aspirin a day. So a $3 treatment could save Black women's lives. We also know that about 700 women die from pregnancy-related complications each year. And the cost alone of caring for mothers with preeclampsia that is treated with low-dose $3 aspirin at 81 milligrams a day exceeds $1 billion annually. When we have these conversations, we often start with the conversation of social determinants of health. I want you to know that social determinants of health are truly a factor in these disparities, but we're not having the right conversations. Let's talk about social determinants of health. So socioeconomic factors are about 40%, physical environment is 10%, 30% is health behaviors, and 20% is healthcare. This is how we describe the problem. When you look at this, the largest percentage is in our socioeconomic factors, and we keep having the discussions across the United States that we are going to address these disparities. We're going to address the social determinants of health. Well, most of the social determinants of health are associated with education, job status, family support, income, and community safety. Yet, no progress has been made in reducing income and wealth inequalities between Black and white households for over 70 years. So are we really talking about addressing social determinants of health, and are we really doing the work that needs to be done? I would say to you that I don't think social determinants of health often are the roots of the inequalities. However, they are factors related to those roots. Because when we look at the most recent data, we see that Black women who are college educated fare worse than women of all races who never finish high school. Education the cause? I don't know. Obese women of all races that have better birth outcomes than Black women who are of normal weight. Black women in the wealthiest neighborhoods do worse than white, Hispanic, and Asian mothers in the poorest ones. So is it income? Black women who initiate early prenatal care in their first trimester still have worse or higher rates of infant mortality than non-Hispanic white women with late to no prenatal care. So is it prenatal care? I want to tell you that I think the right conversation is to talk about racism, not race, racism. Because racism creates these structural barriers that resist access for people of color to health promoting factors, wealth, income, safe housing, quality education, and health care. When we talk about racism, it's the story of racism because this can be seen on many levels. We talk about institutionalized racism, which points us right back to those structures, policies, practices, and norms resulting in different access of goods and services. We talk about personally mediated, the biases and different assumptions about the abilities, motives, and intentions of other races. But we also talk about internalized racism, which is the acceptance and entitlement of negative messages by the stigmatized and non-stigmatized groups. But we want to begin to create birth equity. And so we look at these factors and we try to determine what's the best step or what's the next step to doing this. When we look at the National Birth Equity Collaborative, they define birth equity as the assurance of conditions of optimal birth for all people with a willingness to address racial and social inequalities in sustained efforts. But I want to tell you today that birth equity begins to shift from blaming women for poor health outcomes to system level accountability for programs and policies. And you may be asking yourself, what does she mean by blaming women for poor outcomes? Well, let's talk about some terminology because we use these determinants to describe why women have poor outcomes. And often it doesn't mean very much to the women that we use these terms. It actually means that we devalue them or we blame them for these outcomes. So let's talk about the terms and let's talk about how we can be more equitable in our conversation. When we review medical records, we often find non-compliant. What that means to our mothers is that they have no choice in their decision making. So how about we start with an equitable choice that is low patient activation? We have to begin to activate patients to take ownership of their care, which means shared decision making. We often describe these populations as vulnerable and marginalized, which to them means they have no value to society. So why don't we start by characterizing them as low societal support? We talk about them in the ways of they're uneducated or undereducated. This means that they're devalued. But most important, our mothers tell us that to them, this means that they don't have the knowledge to care for themselves or their children. And we know historically that's not true. In slavery days, Black women cared for their families and their slave owner families. So they don't need to be taught to take care of their children. We could call these communities learning communities. Those people, I have no correction for this term. No group of individuals should be identified as those people. Low income, unworthy of equitable care. How about we start with an equitable term that's underprivileged or non-privileged individuals? And single parents. Single parents tend to imply that fathers are not present or fathers are not parenting solo. And so how about we start with partnerships or parenting solo? And the conversation about race really isn't about the constructs of race, which groups us into different categories of value. It's truly about racism. So we know what the problem is. So we know the problem. Now we must identify what the solution is. So I'll tell you a little bit about what we're doing. We started with working with the Divine Nine, which are the African American fraternities and sororities. And we work with the graduate chapters to develop the Kansas Sisters and Brothers for Healthy Infants, which create awareness around infant mortality and birth equity, because we believe in having the conversation of maternal and child health with the fathers. We modeled this after your own Arkansas, Dr. Michelle Smith, who started Sisters United. We are also building the Kansas Birth Equity Network, which allows us to train 50 diverse stakeholders in birth equity and also to develop a shared community academic research agenda. We are empowering Black families, but how do we start to do that? We started to do that by collecting Black women's stories. And you may be asking yourself, why do we need to collect stories? We know the data, we hear nationally what's happening, but it's time for us to start listening to Black women. It is not fine that the basis of U.S. medicine is do no harm, yet for certain populations, it's not always true. It's not always true for the Black women who look like me. Black women whose bodies were used to determine the best practices for OBGYN are dying at 2 to 3 times compared to white women. And Black infants whose lives were used for productivity and economic gain during slavery time are dying at 2 to 3 times that of white infants. It's not okay. We must begin to start listening to Black women. So we started this by collecting local women's stories. And of course, in COVID, we couldn't talk to these women. We couldn't meet them in person. So we started with an online survey that asked them about 5 different areas: their demographics, prenatal care, their birth experiences, postpartum. And we also asked them to define what birth equity and health equity meant to them. So this was quantitative questions with additional open-ended responses. We also had a Juneteenth panel, which was a candid virtual conversation with mothers, fathers, clinicians, and a doula about maternal and infant health. So what we found were 4 themes out of this. It was satisfaction of care, birth experiences, postpartum depression, and of course, birth equity. When we asked about satisfaction of care, some women detailed negative responses from physicians and other staff, such as nurses and receptionists. So they were having negative experiences with everyone they encountered in their health care. One woman stated she, the doctor, turned a deaf ear to my need of help. Another woman stated, I waited 3 hours before receiving treatment. We asked them about their birth experiences. And what was startling was there were a lot of birth experiences that I never imagined would happen. One woman stated, we need advocates at every level. When I was on the table being cut open by my doctor, a nurse rushed in to stop the procedure, to hand me a telephone, to bring me a nasty telephone as I laid on the table being cut open to get my child, whose heart rate was dropping. It was an emergency procedure. She brought me a phone to let me know that the procedure could not go on until I had a doctor on file who would take the medical card. 2 women stated, I received lots of biased questions. I was married and the doctor assumed I was a single mother. We asked about the father's birth experiences because fathers do matter. And one woman stated jokes were made about the father being present and at one time for him not being present. In 2012, a nurse told me I had the most beautiful colored baby born that day in 2012. One father stated, when we were in there, the doctor really wasn't paying attention to her, my wife. And you know, me being a Black man, I can't go off on the doctor because then I'm perpetuating some stereotype. And the next thing you know, I'll be kicked out of the hospital or worse. We asked them about postpartum, and surprisingly, we heard that many of the women had experienced postpartum depression, but either had not acknowledged it or received treatment for it, or were just afraid to communicate to their community or to their physician that they had it. But one woman stated, I was never asked about my mental health, and although I informed my physician that I was fired while on maternity leave. Another woman stated, I experienced postpartum after all 5 live births. It was the worst. But with the help of a few people in my community and different community services, resources, I was able to persevere. We asked them about birth equity because we wanted to know what can we do to achieve birth equity and what does birth equity mean to you? And one woman stated, people who started our medical institutions, people who teach our organizations, people who train them, don't train them to talk to you. Don't train them how to treat African American bodies, women in pregnancy. One woman stated, this is a public health crisis. I want service providers, advocates, academics, healthcare professionals, community activists, doulas, students, youth. I want everyone at the table. I want Black women to gather committed to equitable care for Black families. So what did we do? We started to gather committed to this equitable care. We started the Kansas Birth Equity Network. And our mission is to use a community-centered approach to create solutions that improve Black maternal, paternal, and infant health in Kansas through training, research, healthcare, and advocacy. And our vision is that every Black birthing person, dad, and infant receives quality and intentional prenatal, neonatal, and postpartum care in the state of Kansas. So how do we begin to do this? We begin to do it by developing a birth equity training. And this birth equity training is an online training that is accessed on our Blackboard, and this has 9 modules. The first is just an introduction to the birth equity curriculum, describing how to utilize Blackboard, because this curriculum was developed for the community and for moms and dads, and also for other community organizations. So not necessarily for just academics. So a lot of these individuals have never used Blackboard. So we have to first begin by teaching them how to use Blackboard, which we all know in academia is very difficult. So we started with an introduction to the birth equity curriculum. We also teach them about the need for birth equity, community engagement for health equity, which was a module developed by your own Dr. Moore, and social determinants of health, health equity and birth equity, sacred births, Black women's experiences, sharing those experiences that I just shared with you, and many more, the uncomfortable truth of bias, and postpartum care. And we end that with mindfulness, which is our first product of the Kansas Birth Equity Network. And these are posters that will be posted in our clinics and in our social services offices that just ask them to stop, look, listen, and think. Stop, look, listen, and think about the care that you provide. Would you provide this care to yourself? Would you want this care? These are crucial conversations to achieve birth equity. Treat people like you want to be treated. It's a human experience. It's easy to do. We are committed to being intentional, and that intentionality means that 1, we increase knowledge through our birth equity curriculum, and we take action, because that means that we're being intentional. But intentional care, what do we mean by that? How do we define it? We listen to Black women and provide respectful care. we include fathers in the conversation of birth equity because fathers are not absent. We must discontinue the maternal and child health conversation in the absence of Black fathers. A CDC report told us that Black fathers are 40% more likely to be active in their children's lives than any other race. So we must begin to acknowledge them. Education and awareness. We also want to create or are creating a resource hub for every Black family in the state of Kansas so that they can go to one place to identify all of the resources that are available to them in the state of Kansas, because they should have access to the same resources as every other family. We are creating solutions to reduce these disparities in a collaborative effort, and we are also creating this 5-year plan to implement solutions. And we will not be implementing these solutions just as the Kansas Birth Equity Network, so us leading them. These solutions will be brought to us by mothers, fathers, church leaders, also by community organizations that are involved. We have 56 organizations involved. All of those organizations or individuals will have the opportunity to tell us what solutions they want to present, and also the opportunity to lead those solutions. Another thing that we do that is very intentional is each year, and this will be our 5th year doing this, we hold our annual Celebrate Day 366. This annual event is hosted by the Kansas Sisters and Brothers for Healthy Infants. This year it will be virtual, but we have had 3 in-person sessions. And this event is very exciting because each time we have these conversations, we talk about infants dying. But this event changes that conversation from death to celebration. And what do we mean by that? We are celebrating every Black baby that lives past that 365 days. Hence, the Celebrate Day 366. During this event, we have empowerment sessions. So our sorority presents on understanding infant mortality and what it means to your community. And the fraternity presents on the importance of co-parenting and fatherhood. And they come together after those empowerment sessions to have a community conversation on birth equity. We also include all resources and vendors that we feel a family would need to create birth equity. It includes incentives, but what we are often most excited about is that at the end of this event, we have a community birthday party. It is a celebration of Black babies living past that 365-day mark. And when we were in person, we had a wall of fame, and we would give postcards to all of the families so that they could write the names of the Black babies that we were celebrating, and we would include those names on the wall of fame. And the idea was to have more and more Black babies living past that 365-day mark every year. All right, so considering that we have taken action as the Kansas Birth Equity Network, I always like to end my presentations by talking about some of the action that we could all take no matter what state we're in. We can begin to create birth equity in our own states for our own Black families. We can standardize data collection. It is so saddening that the data collected during slavery times was more accurate and more accessible than the data today. We must do better. We could start to conduct implicit bias training that includes anti-racism training. And let me explain why that's important. So we conduct implicit bias training, and I do it as well. I teach it to the medical students, and we say, everybody has a bias. It's okay. All you have to do is use these strategies to correct that bias, to address it, and acknowledge that you have it. Well, I'm here to tell you today that if that bias is racism, it is not okay. We cannot continue to have racism as a bias. We cannot continue to put a stamp of approval on that and tell you that it's okay. You have to do better, because sometimes people are the problem. So we must begin to have implicit bias training that includes anti-racism training, and not just among professionals, but amongst all individuals that are receiving education in our institutes, among community members, so that individuals are treated right when they obtain social services, and just among regular community members, so that when individuals are within our community, that they are treated with respect. We must extend postpartum care to 1 year. Right now in the state of Kansas, we have about 30% of our mothers that attend their 6-week follow-up if they're on Medicaid. They don't get an additional follow-up if they don't attend it within that 6-week period. And we're seeing that most of these women experience postpartum depression anywhere between 3 and 6 months. We need to increase the quality of research that is happening around these issues. And by doing that, we would then increase the access of the true data. We also need to begin to dismantle systemic racism embedded in state policies related to housing, voting, income inequality, educational debt, and incarceration. Because in our states, we're operating with laws that create oppression for a group of individuals. So we must begin to correct that if we're truly going to protect our Black women's lives. I never like to end the presentation without acknowledging that these are individuals. They are not statistics. They're individuals who matter to their husbands, their children, their families, and to society. So we must begin to say the names of those that have lost their lives because of pregnancy-related complications. We must begin to make this a human conversation about humanity. So I like to end in saying we have to protect Black women. And how do we do that? We have to be transparent that these things are happening. And we have to begin to say their names. So say her name: Shanice Wallace, Shalon Irvin, Kyra Dixon Johnson, Yolanda Kadima, Amber Rose Isaac, Tatia French, Sasha Washington, Mary Ajuapong. They are individuals. They matter. If you're interested in the work that we're doing, you can always feel free to go to our website to see the work that we're doing. If you're interested in joining the Kansas Birth Equity Network, you can always create an interest by going to this link and applying. Although we have filled our 50 positions in the state of Kansas, we do have opportunities for affiliate memberships. And I know that you don't live in Kansas, but maybe you want to learn about the work that we're doing. You can always follow us on Facebook. You can contact us at the Kansas Birth Equity Network Gmail account, or you can email me. I want to tell you that we have a great team of academics and community leaders. I, of course, lead this work, but my co-investigator, Dr. Michelle Redmond, also co-leads this work. We have Kyla Morris, who is our research assistant. And for our community leadership, we have an advocacy lead, which is Anya Barnett. We have a CD366 lead, which is Joy Barnes. And Joy leads our Kansas Sister Brothers for Healthy Infants. She is an AKA. We have our Father's Engagement lead, which is Broderick Crawford. So we believe in community engagement and bringing this from the community. I will stop there and ask if there are any questions.
I think there's a question asking, are you aware of any online resources showing report cards or similar reports of institutions or health systems comparing their maternal and infant mortality outcomes by demographics?
Oh, that's a heavy question.
A lot.
No, I am not aware. I can say that I attempted at one point in the state of Kansas to identify institutional data and also identify the care that women were receiving and do a peer-to-peer kind of learning activity and using the positive deviant framework, so identifying agencies that were doing better than other agencies but looked similar to them. And that data was about 6,000 per year to obtain, and they would not give me identification numbers to identify the institute. So I don't know if any of that work is being done in any states. I do know that there is an NIH funded project in New York, and it's by Dr. Howe, and she is looking at positive deviant hospitals. I'm not sure of the outcomes of that work, but that is the only work that I'm aware of. But there are no report cards. It's just, who's doing better than their peers.
Lots of compliments in the chat. Lots of thank yous. Any more questions?
Hi, Charlotte. This is Brooke Montgomery, and I've got to jump off, but that was amazing presentation, and it is an honor to have you as a fellow alum of UAMS. Thank you so much for sharing.
Hello, Brooke. Have a great day. It's great to see you.
Thank you.
All right, so we do have some more time if you want to add some more questions in the chat. I just want to put a plug in again for our College of Public Health. Dr. Smith, like I said, is a graduate. So, we are very proud of her and the work that she's doing in Kansas. And I'm putting a plug in. So we do prepare our students to do the type of work that she's doing. And if you're interested in one of our master's programs or our doctoral programs, please reach out. And again, if you are a community organization that's interested in partnering with us in some of the work that we do, or if you're interested in having a student do an internship with you, please reach out to me as well. I'm going to give it a few more minutes just to see if anybody else has any more questions. But I always take, when I start talking, I'm going to take the time to ask Dr. Smith a question myself. So I know you're doing work in Kansas. Are you also doing any work nationally? Because I'm really impressed by the work that you're doing there. And I just wanted to know, have you kind of spread out nationally to do any of your work?
Yeah, great question. So, of course, thanks to you, I am a part of the PCORI maternal mortality network. And so we are doing some work nationally to develop a research agenda to address maternal mortality. It's not as similar to my work, as it's driven more by organizations rather than inclusivity of moms and dads. And other community members. And so I am doing that nationally. And we also have been reaching out to the Black Maternal Council to determine what we can do to support bills that are related to Black maternal health.
All right, so I don't see any more questions popping up. So I just want to, again, thank Dr. Smith for being with us today, and thank Sydney Roper for being our moderator and one of our students that we're going to be proud to boast about and when she finishes as well. We're actually leading into our lunch break. So we will reconvene at 12:30. And at that time, we are going to find out about what's going on with doulas in Arkansas, which I'm excited to hear about because I just learned about some of this work a few weeks ago. And I was just like, what? We have doulas doing what in Arkansas? So I'm excited to hear the presentation myself. So again, you can stay logged in, or if you need to leave and come back in, it is fine as well. But thank you all for being a part of this excellent symposium. It's been great so far, and we have more to come. So we'll see you at 12:30. Well, welcome back, everybody. Hopefully, everybody will have time to get a lunch. And we're going to move right into our next session, which is talking about doulas in Arkansas. And we have Nicole Fletcher from Ujima Maternity Network Incorporated. So Nicole has been a certified birth doula since 2010. She also holds certifications as dancing for birth instructor, lactation counselor, and health coach. She also is trained a placenta encapsulation specialist, a childbirth educator, doula trainer, and mentor. And she is also a founding member of the Ujima Maternity Network Incorporated. She's also the mentoring program director at the Conway Cradle Care, a nonprofit that supports expecting and parenting adolescents to complete their education through mentoring and childcare. She's also a co-founder and executive board member of the City of Hope Outreach, which is a nonprofit organization that advocates for the homeless and under-resourced persons by providing education and housing solutions. Her aim is clear, and the people of God has it her path to continue to be served well. She's a builder to increase networking and birth knowledge, Black birth workers, and empowering supportive community. So welcome, Nicole, and thank you for being here. I'm gonna just turn it over to you. And I did forget to ask if you had any slides to share with us today.
I actually don't have slides today. Yeah, so we're just gonna get groovy. We're gonna do it.
I love it.
That's awesome.
And so we're gonna keep your picture up there so everybody can see your smiling face in both places.
Awesome. Well, thank you so much. I really appreciate the opportunity to be here with you all and really just share about doula work in Arkansas and how Ujima Maternity Network has come together to really advocate and support the birthing community here in Arkansas. So I kind of want to just start with like, what is a doula? I know many people are kind of like, what is that? You know, or they may have heard of it, heard of the work of a doula or the name doula, but just doesn't quite make sense. Or is it a part of the brain? You know, what is that? So a doula is spelled Doula. And the root of the word is Greek and it means woman servant. So as women are taking on the profession of doulas, it has evolved in many ways. So when we look at like ancient hieroglyphics or birth work historically, we see that there are usually three people in that space. There's the birthing person, the birthing woman, then there is the person that's going to catch the baby. And then there's usually someone that is there, maybe that the woman is leaned back on or receiving support from. And so that role is a doula. So here today, we have doulas that serve in the capacity of working with, birthing people or families in the hospital, as well as if they're, birthing at home. But we cannot be confused with doulas being midwives. So midwives are different than doulas. So they're not the same. They're not one and the same. And a lot of people think, oh, well, a doula is someone who helps you birth outside of the hospital. That would be a midwife. And so I can go into all that breakdown, but I won't today. I'm going to try to keep it focused. So doula is, it's a Greek word, it means woman servant. So providing emotional, physical, and informational support for the birthing person, whether that is at home or at the hospital. So if a woman is choosing to birth at home, then she will have, in the state of Arkansas, a licensed midwife, a CPM or LLM that would serve her as care provider for the birth at home. That doula provides that emotional, physical, and informational support. So statistically, that doula is a non-medical birthing person or birthing partner. Another way that you could kind of identify it, I like to describe it as like a personal trainer. So a personal trainer to fitness is as a doula is to birth. You get what I'm saying? Does that kind of help you put some of those pieces together? So a woman will come to a doula and say, this is my birth goal. This is my expectation. I want to have a hospital birth without medication. And so she'll link up with that doula. That doula provides education really for that woman to have the opportunity to birth in the way that she's anticipating. Does it always turn out? Not necessarily, but statistically, we know that having a doula can decrease your chance of C-section by 39%, which is pretty significant, particularly in the Black community when C-section rates are very high. And here in Arkansas, the maternal and infant mortality rate is we're fourth highest in the nation, actually. So that's an alarming statistic when the concerns can be prevented. So doula care really can come alongside a woman, and part of the advocacy of that is actually creating space where this woman can be heard and understood and then empowered to take some of those concerns or thoughts to her care provider. Just last week, I had a woman come in my office who had some questions and some concerns about just kind of her healthcare. And I said, okay, let's break this down, pull out your pad, and let's start ticking off these things. Create a list so that when you go to your care provider, you can ask the appropriate questions and wait and get the appropriate answer. And don't leave till you get that appropriate answer. Does that make sense? If that kind of, I'm usually like a dialogue-y person, so this is different where I can't get like any feedback and I'm like, where are my amen corners? Okay. So yeah, there are different types of doulas that serve here. There are birth doulas. And so a birth doula is one that would serve you during your pregnancy, and she would physically be present during your labor process. So again, providing physical support, emotional support, and that continuous labor support is different. So if a person is birthing in the hospital, the nurse may desire to be fully present with her patient for the duration of that labor, but the reality is she cannot. So this doula is hired by the client and brought in to advocate, to support, to educate that client throughout her laboring process. And then we have postpartum doulas. So the postpartum doula will meet a client during her pregnancy, but then the bulk of her work happens after the woman has given birth and is back at home. So she provides the postpartum doula in-home support, advocacy, and care for the mom at home. So typically you birth in a hospital, you have your initial 1, 2, 3 days of postpartum care support from the hospital staff, and then a woman is sent home and it's not followed up with for the mom for another 6 weeks. And so the doula really kind of fills that gap and connects with the family during that time. Certain things that a postpartum doula might do is, help with sleeping solutions, feeding solutions, making sure mom is taken care of. When a woman has given birth and her focus postpartum is really all on that baby and can't really focus on anything but the baby. And so the doula, the postpartum doula, her focus is on mom. And so that's just kind of a beautiful like marriage that happens with a postpartum doula, as well as with the birth doula, kind of providing that support and emotional advocacy throughout the laboring process. But let's talk about birth in Arkansas. We've all kind of gone through this pandemic and in the variety of ways that we've had. And as a result of that, that has caused doulas to not be in the hospital as frequently as we normally would have been through the pandemic. So that has changed even some birth statistics and birth outcomes as a result of that. So I want to talk about just some of the issues that we're seeing here in Arkansas. And I love what Dr. Smith shared. I mean, everything that she shared was like, spot on, spot on, spot on, spot on. So it was great to hear you share that, Dr. Smith. And I appreciate the work that you're doing in Kansas. So Ujima's work is very similar to that work. We are not as advanced yet, but we are a network of birth workers. We started with a network of birth workers that came together to address the healthcare disparities that exist in our state. So Ujima means collective work and responsibility. It's a Kwanzaa principle. It's the third day of Kwanzaa. And so we've adopted this Ujima name because of its meaning from the Kwanzaa principle. So collective work and responsibility, making the problems of our brother and sister our own and solving them together. So we strongly felt that there was a greater need for Black birth workers to rise up and be on the forefront of change to address the healthcare disparities. Most of the problems that we're seeing that women are experiencing are preventable, right? And we know that. That's already been discussed and it's already been laid out. These things are preventable, but women are often not going to some of their care providers or aren't fully disclosing what their concerns are to their care providers. One, because there's a lack of trust, right? There's a lack of trust. There is systemic racism. There's bias. The hospital setting was not even created for Black women. There was a period of time where Black women weren't even allowed to be received in a hospital setting. And some of that mindset is still existing with us today. And so creating a space where women, Black women, can be heard, can be seen, are valued and understood is powerful. And that's what Ujima is. Ujima is a powerful space for Black mothers to be heard, to be seen, to be valued, to be cared for, and really advocated for and supported. So that's a lot of what we do here at Ujima. One of the biggest things was increasing doula support, doula care here in the state. So I was a doula. I started my training in 2009. I was certified in 2010. So it was a year-long training. In that time, and probably for the following 4 years, I was the only certified Black birth worker or Black doula in the state. And eventually that started to change and more Black birth workers came on the scene. Even looking at my clientele and my history, I serve about 30 to 40 women a year on average. And with that, I, in my first till 2018, I had served like 10 Black women, 10 Black mothers during that time. And with a clientele of 30 to 40 women annually. So that says a lot to me. That says a lot that our community didn't understand that this was a service that was for them, that they needed this as well, and even more so than everyone else. So I feel like all women of any experience, any ethnic background need this type of advocacy and support, but Black mothers more so, right? Even more so, because lots of spaces, they're not heard and valued, oftentimes dismissed. And doulas can catch things that care providers are overpacked, their schedules are too packed, and they can't or sometimes don't get into the weeds of what's going on with a woman and can dismiss them very easily and very quickly. So doula support really kind of fine-tune combs all of that information and really acts as a liaison or a catch-all between what may be missing from a provider and a patient. So it's not that the doula is in the middle of or interjecting, but the doula is asking questions and helping to empower that mom to make meaningful decisions for her own birth experience. And how do you do that? Well, we have to have education. We have to educate. We have to show these are options that are available. I can't tell you how many women I run across, and they say, I didn't know that was an option. I didn't know I could do that. I didn't know I had the choice to do this, that, or the other. And so having a doula allows and opens up that space for you to have choices. So Ujima is networking with doulas around the state, and then going to places where there are deserts, if you will, so like healthcare deserts, and really networking with women in that area to raise up doulas that live in those areas, because we do believe that if you have doula support and advocacy in the pregnancy and in the postpartum period, with someone that is local to you, your access is greater and you're going to be more helped and have more care, and have a better outcome overall. Just by an example, I do want to share this story. I had a mom that was 9 days postpartum. And this was here in Central Arkansas, 9 days postpartum. I woke up to a phone call. It was 5 a.m. and she was screaming on the other end. I wasn't on call at the time, and I just happened to answer this phone call. I was like, oh, my phone's ringing. And I really kind of woke up in a panic, actually, because I was startled. But anyways, I grabbed the phone, opened it up, and it was a FaceTime call from a Black mother of mine, a client that had delivered her baby 9 days earlier. And she was showing me just her underwear that was just bloody, and everything was just, I mean, she showed me a trail of blood that was just all over the place. And so she was hemorrhaging. And, you know, I'm 45 minutes away from her, but definitely wanted to help and do something. We needed to help save this mom, because she very well in just a few minutes could have been a statistic. So we did our due diligence, got her to the hospital. It took several hours. It took 5 hours for her to actually be seen in the OR, as she needed to have been 5 hours prior. And the whole time she was bleeding and passing out through this process. So just that little bit of connection was huge, because she needed someone in that moment that she could call, that she could contact. Care providers are amazing, but they're not taking calls from their patients at 5 a.m. in the morning to address some of these healthcare issues that are happening. Postpartum hemorrhage is a big concern that mothers have after delivery, particularly Black mothers. And so this mom could have been a statistic had we not acted as quickly as we did. But even then, she's a nurse and had to advocate for herself in taking her own blood pressure and doing some things that the hospital should have been doing for her. And it was not done. So little things like that aren't little, they're big, and they're happening a lot. So having doula care can help catch some of those things and redirect some of those issues that might be happening. So that's one of our big things. Our big initiative is to kind of connect with women all over. We also do monthly clinics. The monthly clinics we provide as an outreach to the community. So women that are expecting and even in their postpartum period can come to a clinic and maybe get reassurance about what is happening in their pregnancy. Is this okay? Let's dot our I's, cross our T's. Let's provide some additional support. We do physical comfort techniques and really just kind of connect with the women that are in their pregnancy in creating that space where they can be seen, heard, and valued, where we sit and listen to the moms and they talk about what they're experiencing. They talk about the emotional stress factors at home, and we provide solutions, or we work to provide solutions to make it easier for those moms to manage, to decrease their stress levels. So the March of Dimes has recently graded the state of Arkansas as far as premature births. Well, we got an F, and that's a problem. And those things can be fixed if we were to tune into them. So we're in a healthcare crisis for Black mothers, though we're neglecting to address it as such. So our society and our community is being dismissive and passive of these issues that we're having. So if you have a premature baby, you have lots and lots of complications that are added on to both that mom and that baby in that postpartum period. So we want to help reduce that rate by making sure that moms are healthy. We can just, let's talk about your diet. What are you eating? What are you drinking? Why are you eating and drinking that? What health hazards are you just doing as your daily habit that might need to be adjusted for your pregnancy to have a healthier outcome during your pregnancy, to make sure that you have a mature birth baby or a mature weight with the baby. So that's important. So we ranked, we failed, and then we're ranking 4th highest in infant and maternal mortality. So we have a public health issue that everyone should be crying out about to address and make different. But it's not happening. So evidence-based birth tells us that statistically, continuous support, not from a family member or someone known, so the role of a doula, someone who's hired on for this, really does allow women to have better outcomes when it comes to birth. So again, a decrease in cesarean rate by 35%. Also, a 15% increase in spontaneous vaginal birth outcomes. Also a 10% decrease in medicine for pain relief. So when we look at all of these things, when we're decreasing the cesarean rate, we're also saving money. So I think people are like, oh no, a doula costs money. Well, I think all things cost money. So if we were to shift our mind to say, a doula is important and valuable in our maternal health system, I think we would all, not just think, statistically, we would all fare better in that process. So I think that's what I have to say. Okay, there's questions.
All right, so we do have one question there in the chat. It says, can you give an overview of what payers, if any, cover doula services in Arkansas?
Mm-hmm. That's a great one. So most of doula services is an out-of-pocket expense. Some Cigna is an insurance carrier that does actually cover, and it's reimbursed. So Cigna Insurance reimburses for doula support. That just started in 2000. I think it was 2019 that Cigna started that, I believe, the late 2019. Most of it is out of pocket. Ujima also has a scholarship fund. So we are a 501c3 nonprofit. And so we do raise funds and donations. And last year we scholarshiped a mom $1,000 to have an out-of-hospital birth experience. We've helped a postpartum mom that was dealing with some depression. She provided services for her to have a postpartum doula. So expense is a thing, and it can be challenging for some, but most doulas are also willing to work with you. So Ujima, again, will help cover cost when necessary and if necessary for a family to have physical and emotional support and information during their pregnancy and postpartum.
So we do have opportunities to add some more questions to the chat, but I'm like to fill the space with my own questions. Yeah. So I'm curious to know, for those of us who are here on the call and work at the university, how can we advocate on the behalf of doulas? Like you mentioned, we're looking at birth outcomes, and that's what all of us want to have, nice, healthy babies and moms that not only surviving but thriving throughout their pregnancy and then after they give birth. So how can we help advocate?
I make it easier for the birth worker, for the doula, to be in this space. Just make it easier, make it more friendly. I think there have been times when nurses and even obstetricians feel like doulas are in opposition to them. And I think part of that has been because now they have a patient that is maybe thinking a little bit more, maybe asking a few more questions. And sometimes because of their schedules, they're not very interested in that. Or maybe wanting unmedicated labor. So, and I'm going to say this, and this may be controversial, but many obstetricians prefer medicated labor for their patients, right? It seems like that outcome is a little bit more controlled and less unpredictable. Well, labor, unmedicated labor, is unpredictable. Birth in and of itself is unpredictable. And so having a woman choosing that as an option, I think there needs to be more advocacy and more support for women who choose alternative options. Does that make sense? If that makes sense at all. So how can your institution be helpful? I'd say make it easy. Have the conversation. If an OB would just even say like, hey, do you have a doula? Have you thought about a doula? Guess what? A lot of burden is taken off that OB, because that doula is going to go through like a detailed nutrition plan with that client, where the OB is not going to do that. They're going to say, are you drinking water, and throw some of that out there just for time's sake. And I have to believe that people go into this field because they love it. They're passionate. They care about women and they want to see babies born and have great outcomes. But then the reality is, when we get bombarded with our day-to-day activities, right? And like the demands of the jobs, the paperwork, all of these other things, we lose sight of what's most important. So that doula is hired by that client. And so that client is the number one person in that doula's life. Where with the obstetrician, that client is one of many people. And hopefully that helps.
It does. I see some additional comments in the chat in regards to just what states are actually, there are currently 4 states that have enacted state bills for doula care: New Jersey, Indiana, Oregon, and Minnesota. And this is through Medicaid. We also have a thank you for your presentation and a question. How have doulas been able to navigate the barriers of supporting birthing individuals with COVID restrictions?
Yes. I just want to take a deep breath. Because it's been very difficult. It's been very difficult. I think for everyone around, and I think when COVID first kind of hit the scene in March of last year, I was dealing with clients that were right in the middle of what's the hospital going to do? What's the hospital not going to do? What are the options? Oh my gosh, is my doula going to be considered a person that can come or not? Like, what is that? What was going on there? So we adapted, and that's basically, I mean, that's what we did. And by adapting, I mean, moved to all virtual services, moved to online care. For clients. Now, through COVID, I felt it was still important and necessary to have a face-to-face, hands-on connection with my clients. So I did do my prenatals at my client's home in person. I felt like that was very, very important, especially when telehealth, even with their OB, was happening. So there was a lot of care that was missing and was just fell short. So it was difficult. So we did as much in person as we could during the pregnancy or the prenatal part. I was able to labor a little bit at home with some of my clients and then transition them to the hospital. And once they were at the hospital, then I would go on FaceTime and do Zoom. The most ideal was like a laptop, like kind of up, and you could see everything in the room. And so I've been a birth worker here for a while, so it was nice and maybe a little bit easier for me. So the nurse like could hear my voice and go, "Oh, that's Nicole. Okay," and then we could still kind of work together as a unit. I think it was harder for doulas that were newer. So a newer doula, I felt like may even have had a harder time navigating that. I mean, if that camera doesn't hit the right angle, you don't know what's going on and you can't really advocate or bring up the things that are necessary. So it was a challenge. And I felt like that physical support of the doula, that role, that was missing. And we did everything we could to prepare our fathers, the fathers or whatever support person was in the room, to actually do the things. And so it was better in some sense than I expected and worse in some ways, if that makes sense, or just difficult. But the physical support, so what we would do is prenatally work on those physical support techniques. So then I could call it out and say, okay, let's do that counter pressure thing. Remember that we talked about? So dad could get in there and physically help. I do feel like some of the nurses actually stepped up and really kind of would do some more than what they would normally do. I think because they felt, their heart were broken as well for the situation. So it was challenging, but in summary, we switched to all virtual support when they were in the hospital. And then when some of the hospitals released they kind of moved doulas to be considered a part of the birth team. So that helped significantly. That helps significantly, so we could physically be present with our clients. So that was very helpful.
Great. And I'm going to just read some more of the comments in the chat. One person said, informed choices around birth is so important. People need to know their options and feel empowered in those choices they make. And I think, like you mentioned before, about people don't even know what doulas do or what they are, or they're even available or accessible. And so we talked about or heard about informed decision making. And I think being able to know what all your options are is very important, so our patients can make those choices.
Yeah.
Another comment, great presentation, Nicole. Great presentation, Nicole. Everybody love it. So you are doing amazing work, and thank you for all you do. And it's always great to hear you. Great information, beautiful presentation. Thank you for the amazing work and other doulas are doing in Arkansas. I don't see any other questions so far, but I think you must have just covered it because everybody's just loving the information. But how do we get in contact with you all? Let's say if is there someone who wants the services or interested even in donating or connecting with you all somehow, what's the best way to do that?
So I began, like while you were speaking, I typed in our website. So our website is going to be like your first go-to place to just find information and get more details about that. And that is ujimamaternityNetwork.org. So that's going to be your first place to go. Also, if you are interested in becoming a doula, I used to train doulas myself, and because of the work that I'm doing, I'm also in the process of becoming a licensed midwife here in the state of Arkansas. So I'm a student midwife now. And part of that is also there are no Black midwives in the state of Arkansas. And we know that Black mothers fare better when they have out of hospital, for low risk moms, out of hospital birth experiences with a care provider that looks like them. So myself and 2 other Black birth workers have now moved to become student midwives or apprentice midwives. So that's one way. Another way to kind of get connected is, oh my goodness. Another way, if you're interested in becoming a doula yourself, because we want to branch out and spread this. So there's training through Ujima Maternity Network to become a doula. There are 3 different methods or 4 different methods. There's a 3-month, 6-month, 9-month, and a 1-year training to certification to become a doula in the state of Arkansas. Now, there is no regulation on doulas as far as licensure is required, so you do not have to be certified to serve in the role of a doula here in the state of Arkansas. You do have to have a license to become a midwife here in the state of Arkansas. So the rules are a little bit different for different types of care. But if you're interested in becoming a doula, which is, I feel like, is your groundwork, right? You need that groundwork. You need to be able to get comfortable with waking up at 2 a.m. or 3 a.m. to a phone call for a woman that's in labor, and then being able to answer that call and respond. That work isn't for everybody, but maybe you're still passionate about it. Maybe you need to be a postpartum doula where you can schedule those things, and you're not necessarily going to take that 3 a.m. phone call and have to pop up and go respond to someone. So those are things that are options and ways to connect. Donations are always welcome. Sing it again, always welcome. So again, we are a 501c3 nonprofit, so we accept financial donations that can be done through our website. That's all there. We also host these community care outreach clinics. And when you do that, those are free to the community. So when a woman comes through, that's free. We have licensed midwives that are overseeing the process and working with us to care for them. So we're not just out here doing all the crazies, but things that women can experience when they come to the clinic. We can do well woman exams. If you're pregnant from 4 weeks to 32 weeks gestation, we can see you. Moms that are postpartum or within the first 6 weeks, we can see you there. We can do newborn exam, and we can do preconception counseling, just really talking to you about what's going on. Here's our little flyer I want to show you. It's cute. And then here's the back, and there's all the dates. So they're every second Saturday of the month here in Conway. At Hurley Chiropractic. We've just recently established a partnership with Our House in Little Rock, and we'll be doing a clinic there sometime in September, the end of September. So we're looking forward to that opportunity to really branch out and fill the holes in maternal care here in Arkansas. And over the next few years, we're looking to see, I want better than an F from the March of Dimes, right? Like, could we get a C? Let's work towards a C. Just start making these small changes that improve quality of care over time. So I love it, and I'm so thankful. And we also have some great partnerships with Dr. Zenobia Harris. So there's some amazing things happening on the scenes, and we're looking forward to doing more.
That is great. Also, I see someone has dropped in the chat, the Facebook page as well, so people can access that or the website. And some more, just you're amazing, Nicole is in the chat as well, which is awesome. And so unless there's more, which I'm going through, I don't see any more questions. Again, I just want to thank you for being with us today, and I'm excited for my own knowledge to learn more.
Mhm.
And like I mentioned, I just keep mentioning our students and our College of Public Health. And we're also with our Motherhood Together program, working with our house. So I'm hoping we'll be able to connect more in the future around those services as well.
Yes.
So that sounds great.
Awesome. I've been looking forward to meeting you for a long time. So I see your name on everything and I'm like, I need to know her. And
yeah, I'm all over the place. I need to sit down somewhere, but COVID has slowed me down a little bit, but it has not stopped me. So it's great to see you, and we'll definitely be in contact as we move forward.
Awesome. Thank you so much.
Right. Thank you. And so we do have a couple of breakout sessions coming up. For those who are interested in learning more about pregnancy support to improve birth outcomes, as you can see, you can actually just stay right here. That session will be starting at 1:30. And so Nicole did mention Dr. Zenobia Harris, who is an awesome woman as well. And she leads the Arkansas Birthing Project. So she will be a part of that session and actually leading that session along with Dr. Greenfield, who works between here at UMS and the Arkansas Department of Health. And like I mean, they'll be talking and having more of a conversation. So for those of you who like a little bit more dialogue, these breakout sessions will definitely provide that for you as well. So if you're interested in pregnancy support to improve birth outcomes, you can just stay right here into this Zoom. But we also have another breakout session starting at 1:30, and that is pregnant and lactating women and COVID-19 vaccine hesitation. And Ms. Shakia Jackson will be actually the moderator for that session. And we have Dr. Gloria Richard Davis, who is also here at UAMS, that will be talking just about, the COVID-19 concerns. We talked about some of the restrictions as far as, who can be there, within the hospital setting and those types of things. But then, as we're moving towards now getting more people vaccinated, there's a lot of concern, a lot of talk around, if I'm pregnant, is it safe? If I'm, lactating, if I'm still breastfeeding, is it safe for my baby? So we wanted to provide that space to get some education out there and the conversations around that topic. So if you're interested in joining that, you're going to actually have to leave out of this Zoom and then log back into the code there to enter is there. And Ms. Jackson will be, like I said, moderating and leading that session. Again, I just want to thank everyone for being a part of the symposium. This has been wonderful. I am so grateful for the partnerships that we have in order to bring all this wealth of information to one place. I'm putting out again that if you did register and you was one of the first 100 people, within the next 4 to 6 weeks, due to shipping and processing, you will receive your swag bag, which we picked out, and I think everybody will enjoy it. And so just look out for that in the mail. And again, we'll be doing this next year. I'm hoping that we'll be face to face. So I like the opportunity to be on Zoom, but I like even more to be in person, to be able to see everyone and to, like I said, I like to eat. So, and to share a little bit of food along with those swag bags. So I'm going to sign off here. And like I said, we'll be back at 1:30 here with pregnancy support to improve birth outcomes. And if you want to join the COVID vaccine hesitation, please log off and then log on to the other Zoom session. So thanks again, everyone.
To our talk with Dr. Greenfield this afternoon. My name is Zenobia Harris, and I'm Executive Director of the Arkansas Birthing Project, which is a mentoring program for pregnant women. We train community volunteers to provide social supports to women during their pregnancy and for the first year of life of their babies. And we're real excited to participate in this discussion this afternoon with Dr. Greenfield on pregnancy support to improve birth outcomes. Dr. Greenfield, I'd like to just tell everybody a little bit about you, and then perhaps we can start a brief discussion. And if you have a prepared presentation, do you have a presentation that you want presented on the screen, Dr. Greenfield?
I have a few slides put together just in case. I wasn't exactly sure what the best flow would be. Conversational may work best, but I've got a few things that may be of interest as we kind of go through.
Why don't we begin with those things? Dr. Bryant, can we share the screen with Dr. Greenfield, or?
Yes, he has the capability to share his screen.
Great.
Okay,
all right.
Let me get.
Well, let me do a brief presentation, introduction for you, Dr. Greenfield, and then we'll proceed on with your presentation, your slides, and then in our turn discussion. Dr. William Sam Greenfield completed his medical degree at Meharry Medical College in Nashville. He completed an internship at Baylor College of Medicine in Houston, Texas, and his residency in obstetrics and gynecology at the University of Arkansas for Medical Sciences in Little Rock. Before he attended medical school, he received a pharmacy degree from Auburn University. His clinical interests are in obstetrics and gynecology. He's trained in Da Vinci robotic surgery, and he's made presentations nationally, regionally, and locally on topics in his field. He currently serves as the Arkansas Section Chair for the American Congress of Obstetrics and Gynecology, and is a member of several professional organizations, including the Arkansas Medical Society, the American Medical Association, and the American Society of Colposcopy and Cervical Pathology. He enjoys both his obstetric and gynecologic patients. He likes to help educate his patients and guide them to make informed decisions about their health care. Dr. Greenfield?
Well, good afternoon, and thank you very much for a fantastic introduction, and thank you to the organizers of this event for putting it on. I'm going to share my screen here in just a moment. Let's see. But before I do that, I'll just kind of amend and add to the introduction a little bit. Over the past several years, I've been on faculty at UAMS. I'm an obstetrician gynecologist, and I've been on faculty over here for about 17 years. And in that capacity, obviously, I take care of women who are going through the birthing process and pregnancy. And obviously, but more importantly, I'm a father. And after doing this for many, many years, one thing I can certainly appreciate is the time when I was the husband sitting next to my wife in the OR, after being in the very room that I have worked in for over 20 years, sitting in that chair as a supporter of my wife as she was going through the birthing process. This was totally different than that as a healthcare provider. So when I'm speaking to you, I would like to think that I'm speaking to you, one, as a person who has professional expertise in the work that I'm doing, but also as an advocate, as a husband, and as someone who is looking out for the best interests of not only my family, but families across the state of Arkansas. So with that said, I want to start to see if I can share this screen. And Dr. Harris, I will ask you just to kind of correct me if the screen does not share properly. I'm working from two screens here. And let's see. Screen two. Okay. And okay, can you tell me what you see? Are you seeing anything? I can't hear you, I'm sorry.
Yes, I see improving birth outcomes.
Okay, so I have a few slides, it's about maybe 12 slides. And what I want to do is just start with the beginning here. So 100 years, not 100 years ago, but back in 1950, the Journal for the American Medical Association basically almost declared success on maternal outcomes and maternal deaths. We had had significant improvement in terms of maternal health outcomes compared to where we were at the turn of the century, where we had significant numbers of deaths. And you could see when you look at the trend line here, with some efforts to sort of what one may call medicalization of birth, there was some improvement, but largely there was the initiation of prenatal care. You see an uptick back in about 1918, which correlated with the Spanish flu. You can see deliveries in hospitals, cesarean deliveries, blood transfusion, a host of things actually drove down the maternal death rate. But despite the fact that we've had a significant improvement in the developed world, still worldwide, about 830 women die from preventable causes of death. About 700 women in the United States die from pregnancy or delivery-related complications. What we do know is that skilled care before, during, and after childbirth can save the lives of women and newborns. And despite the fact that we have had significant improvement, we still have a little bit of work to do. And if you've seen the news in recent years, you may have seen these issues, a lot of attention that was drawn to the fact of that we had rising maternal mortality rates in our country, despite having a high resource setting. There was an article in ProPublica, and I strongly encourage everyone on here to go back and read Nina Martin's expose, because they actually did a detailed dive into the lives that were lost, where each one of these dots on this screen actually represents a life that was lost. If you look at the causes of maternal mortality in the United States, this is an article from May 2021 in the Green Journal, which is a core journal for obstetrics and gynecology. And these are causes of maternal deaths: circulatory system diseases, chronic hypertension, liver disorders, ectopic pregnancy. We'll talk a little bit about that, preeclampsia, and other conditions. So these are the causes of maternal mortality. And when we talk about maternal mortality, we're talking about moms who die up until a year after the end of their pregnancy, okay? I'm going to come back to that slide in just a second. But another issue is maternal morbidity. And so this is really, I think, the greater issue as we talk about it, because maternal mortality obviously is very tragic, but it largely represents a smaller number where, in fact, maternal morbidity, these are the moms who really get sick, whose lives who are in jeopardy at and around the time of delivery or through their pregnancy. And this number may be as high as 8 to 1 compared to those who actually passed away. So this represents an opportunity where we really need to make an improvement. And the question becomes, does bias play a role in that? And there have been some studies that suggest that, yes, it does. It may be biases that result from the providers or the system. There may be biases that result from how patients interact with the healthcare system, how they engage in the system. Is there trust in the system? Is there trust from the system to the patient? And this dynamic that I think is an interplay, which sort of leads us to sort of where this discussion, I hope, goes today. In the state of Arkansas, we have had certainly a disparity that persisted. We have a maternal mortality rate that is higher than most states in the country. We've had maternal mortality disparities that have shown up across the country, and Arkansas is no different. The disparities impact us based on ethnicity, based on age as well. And again, they represent opportunities. If you go to the number of deaths the number of births in the state of Arkansas, these numbers are a little bit old, but they hold pretty consistently between about 35 to 39,000 deliveries per year, simply to give context for our discussion. And if you were to look at our 5-year combined maternal mortality rate, you can see where we are. And so if you were to say out of those 35 to 39,000 deliveries that we have per year in the state of Arkansas, we may lose somewhere between 35 to 40 women who may have a death during or at or around the time of their delivery that may be related. So the CDC has put out some guidance and some resources that I think are very important, addressing severe maternal morbidity, which, like I said, includes the range of pregnancy-related complications that may occur at and around the time of delivery and may go out beyond delivery. And the burden can be shared equally between commercially insured and Medicaid insured moms in the state of Arkansas. Medicaid makes up a large percentage of the patients who actually go to delivery. If you look at the most common causes of severe maternal morbidity, indicators after discharge, blood transfusion, sepsis, which is an infection, adult respiratory distress syndrome, acute renal failure, eclampsia, cerebral vascular disorders, and as I mentioned earlier, heart failure, pulmonary edema. So these are just things to be aware of. Some of the resources, and this is where I think I'd like to take this conversation, is the question is about support. And I think I've been doing this for about, like I said, all total in terms of training and faculty, sitting right at about 20 years. I absolutely am incredibly honored to be a part of the families that that are a part of Arkansas. And I am dedicated to providing the best patient care that I can. I do know my limits, however, and I know that no matter how much I advocate or how much I care, I can never care for a patient quite often more than they can care for themselves. And I think we have to make sure that we give patients the resources, one, to support themselves, for families to support themselves. And this Hear Her campaign is, I think, a very good, useful tool to help start a conversation, because the support that patients need sometimes is how to begin to ask questions. And I think if you look at the template from CDC, you can use this as a guide for starting a question for when you go to the doctor. The reality, as we know, is that when you go for your physician's visit, the system actually requires this. It's sometimes not as personal as we would like it to be. And if I have a patient who is not efficient, or has not, or is timid, or is not assertive, or does not have someone there to advocate and to assist that patient through that opportunity, there may be a lost opportunity to have an impact on their outcome. So that's where the support issues come. The last thing I will say, I just want to make sure that everyone is aware that while we start talking about support and advocacy and things that we can do individually, the support, the advocacy, and the things that we do should be on a patient-by-patient basis, but they certainly can and should extend to where decisions and influence are actually being made. So for example, in the state of Arkansas, we have an Arkansas Maternal Mortality Review Committee. And that committee is charged with reviewing each of this committee is charged with reviewing each of the maternal deaths to begin to identify what was associated with it. Was it truly pregnancy associated? Was it pregnancy related? And to make recommendations to address those concerns so that we can drive our number down. Every life that is lost, that is pregnancy associated, and sadly, some of them may not be preventable, but studies have shown that when we've looked at them, as high as 50 to 60% of those, in fact, may have had an opportunity somewhere along the course of their care, from the prenatal visit through the postnatal visits, through their ultimate demise. There may have been an opportunity to intervene. Secondly, there's an Arkansas Perinatal and Maternal and Perinatal Outcomes Quality Review Committee, which is working to improve and standardize care and efforts across the state with our delivering hospitals. There are about 39 delivering hospitals across the state that are dedicated to providing quality maternal and prenatal and postnatal care. And we're actually looking at those hospitals and trying to identify opportunities to measure outcomes and to make recommendations. So that's the end of my presentation, but I wanted to use that as a starting point for our conversation. And I will end my share now. Thank you.
Thank you, Dr. Greenfield. Certainly, I think it's important for us to talk about all aspects of response and care that are available to women during pregnancy, in terms of not only during pregnancy, but during the intrapartum period, as well as the post-conception, post-delivery, that contribute to the well-being of a woman and her child. There are so many, we've had a really rich discussion this morning about doulas in Arkansas and some of the other birth workers and birth supporters that are out there in our communities that perhaps many women don't have access to. And so, and as we learn more about the work that they do and the influence they have upon birth outcomes, it becomes very reasonable for us to expect that perhaps that's an area that needs to be further investigated, researched, and taken into consideration in terms of improving the health outcomes of women who are pregnant and delivering in our community, particularly in Arkansas.
Right, I agree. When you look at, I mean, there have been studies that have shown that when mothers have support, and the studies have shown it with doulas, that they've had improved outcomes. Okay, and this carries it, whether or not that may be a doula, we've certainly seen it with other efforts as well. So I think certainly, it goes to reason, and furthermore, getting beyond reason, the data can support that when you have maternal support through the prenatal visit, then and through that postpartum visit, that will make a difference. So I am certainly in support of that. Within the medical community, admittedly, there at times there may be resistance because there may be lack of understanding, and there may be breakdowns in communication. And ideally, you would like to have these conversations and these things evolve throughout the prenatal care, throughout the prenatal visit. Now, certainly with 2020 and what we've experienced when we have been in it's been awful. I mean, you have had families moms who have been through some of the most trying times of their life, and they've been there by themselves. I mean, and it's gone on all spectrums of birth and on the other side of the health spectrum in terms of, end of life care. But certainly I think this is a time that is right where everyone can actually appreciate the value of support, because if you have never had a child, personally, I've never had a child. So I could say, well, I don't really know what the value of this is. And I could, make a very weak and anemic argument because it did not personally affect me. However, if I was a person going in for a cardiac cath and all of a sudden I realized that my wife can't come with me, now we begin to see that value does extend to everyone. And so I think we're in a time that's actually ripe to have these discussions to encourage more support.
Well, I had the opportunity to be a part of a telehealth project during this pandemic that was trying to look at how we could use telehealth to reach women that because of COVID weren't getting the kinds of support that they needed during pregnancy. And we had some really interesting connections with the breastfeeding community and with some networks, some maternal health networks in Arkansas regarding using doulas and other support people to go in to meet with women and talk with them by phone and about using Zoom meetings to actually just establish some relationship and to also to share information so that they weren't totally left, sort of out there by themselves or out there with any kind of resources. And I think it shows a lot of promise in terms of using telehealth, particularly in rural communities in our state where many women don't get access to those kinds of services that might be more readily available in urban communities, or to women who just don't have the financial resources for those kinds of supports. So I think there's some very interesting and promising things in the horizon regarding the use of telehealth and texting and social messaging to reach people with information and support that perhaps we haven't used as extensively in the past for various reasons. I even saw some loosening of regulations regarding the use of telehealth and telemedicine during this pandemic because of the like you said, the unthinkable tragedies that have occurred because of the disparities that exist in health status between in our communities, and particularly among Black women in the birthing communities.
Yeah, I agree. At UAMS, for example, I've been doing telemedicine in some shape, form, or fashion for about 15 years. Okay, we've been doing it for a very long time. However, I think it simply required a major disruption like we experienced last year to actually push this into the mainstream. A year ago, 2 years ago, we never would have even had a meeting like this where we'd have this type of attendance on a Zoom platform where everyone is engaged. And I'll be honest with you, I think this is a fantastic thing. It is not going to go away. As it relates to healthcare, it is sad that you can sometimes make predictions about health outcomes when you look at geographical codes, when you look at zip codes. Now, why are the barriers? The barriers are there because one, on a routine prenatal visit, I may have someone who has childcare issues, who may live in a rural part of the state, who may not have the resources to travel for a visit that, in honesty, may last 15 or 20 minutes in the room with me and 3.5 hours round trip going back and forth. those are unnecessary barriers that we
Yes.
certainly have the capacity to overcome. And I think with telemedicine, two things. One, we've had the technology, but now we've had the acceptance. And I can tell you as a part of my practice, if telemedicine visits are a routine part of it, where I've had telemedicine visits where a patient stops and goes into the corner of Walmart and we are talking and we're going through the essential components of that visit. Is it as good as some of the components that we may be able to do in person? I may have some question there, but I can certainly say that it is better than missing a visit. That part, because particularly when you add the video component and I can actually read the room, I can get a little bit of nuance in terms of does the patient actually understand? And to be perfectly honest with you, when I have that conversation, I have sometimes it seems like we're a little bit more locked into facial nuance on a video visit because we are directly looking at the patient. So I think telemedicine is certainly a good thing. It is here to stay. The economics of it and the politicians who make those rules, that I think that gets to the other issue where we get into a community piece where we have to not only support individuals as a patient advocate or as a support advocate, but we also have to be able to advocate for our patients at the next level when rules are being made, because medical care is incredibly expensive. And if, for example, if the telemedicine support goes away, then you maybe end up taking care from folks. And that's certainly not a good thing.
Absolutely. I think we'd be remiss to have this conversation and not mention the Black Maternal Health Momnibus Act that Representative Lauren Underwood has sponsored in Congress in 2021. Of course, that act, there are many, many things that it addresses, but it also looks at how using traditional as well as non-traditional ways of supporting women during pregnancy and afterwards in local communities is that be examined in all across our country so that we can get the full benefit of the resources that exist in our communities. You know, I for one believe that there's a great untapped resource in our communities of community volunteers, women, people who are interested in improving the health status in our communities, but maybe need a little extra encouragement, a little extra information and training and support so that they can in turn share that information and provide support to someone else in their community. And as a person that's coming from a community of women who have been in that space for 20 plus years, we have seen some very amazing results happen as a result of that kind of connection. We're actually establishing almost more traditional family type connections with people in our communities in order to help them bridge that gap that they experience in the birthing space, and also provide a more supported environment for them in the birthing space in order for them to have better outcomes through the Arkansas Birthing Project. Yes. Of course, I think I think it's going to be important though for the Birthing Project as well as other organizations and groups that support women in the birthing space work together so that we can fill in all the little gaps that exist in terms of the support systems that women need and have available to them in communities. And I certainly think there are enough of us out there now for us to have some real serious discussions about how we can better utilize the resources that we have at our disposal and better put that to use in our communities in order to improve the health status of women in the birthing space.
Right, I agree. I think, I would even say over a continuum of a life cycle. I think about starting families at the time when people are ready and prepared to start a family. That is a purposeful event, one, okay? Which is issues of access to contraception when it's needed, when it's desired, reliable, affordable, and readily available. Access to prenatal care when it is obviously when it's going to be needed throughout the course of care and through the local health units, through the health department. We provide prenatal care through the health department. We provide, there are a number of providers across the state that provide prenatal care throughout the course of the healthcare visit. throughout the course of the delivery and then back to the home. And I think that is an opportunity where engagement with community health workers could be very valuable, based on what the resources are and what the need actually is. One program that UAMS has is called Centering. And the Centering program is really interesting in that it is a birth cohort and then studies have shown that that those moms who have had gone through a centering program where they are linked to other moms who are of similar gestational age, and they sort of share a prenatal visit, not the personal details of the visit, but the educational components. And they go through this cohort together. That support has actually been shown in cases to lead to decreased preterm birth. Now, and then you can think about it, if you decrease preterm birth, then that cycle for the next generation starts again. So that's one. Efforts back to the issue with contraception is needed to lead to adequate and successful birth spacing intervals so that someone has an opportunity for their body to fully recover from one delivery to the next delivery, and to, in fact, establish the support that they actually need. I mean, when I think about this issue, it's sometimes what can be a challenge or very enticing is to link onto one piece. And that may be good if that's your bailiwick and that's what you do, okay, that you provide that support on that one particular piece. But I think as we start thinking about the community, as we start thinking about the patients as a whole, it really, in my opinion, I think it's going to take all of these things. And it's going to take acknowledgement that when we learn more, we do more. I'll give you an example. Yes. When we look at maternal mortality. We've talked about maternal mortality for the past several years, and we've shown that it looked like maternal mortality rates in the United States were certainly increasing. There's an article that I recently read that showed, well, maybe the rates weren't increasing as high as we thought they were. Okay, so they're not increasing as high as we thought they were, but nonetheless, they are high. That's one issue. And number two, the disparity is still the same. So we could say, well, if we increase access universally to everyone and everyone's got care, that's going to make a difference. But the same study showed that in England, where they have nationalized healthcare services, that the disparity rates between Black people in England was at a rate of 5 to 1, where in the United States it was 2.5 to 4 to 1. So the point being is that we will ask the hard questions. We will do the work that is necessary to do, and we know that we'll have to do that. And if we find out more and we need to modify and tweak and adjust what we do, then we do it based on the data. So, but I think we have a lot of opportunity, and I think a conversation like this actually goes a long way.
We want to certainly open up this conversation to others that might have questions or who might have comments to make. I see in the chat that someone has commented that someone may be interested in becoming a community health worker, and I'm assuming that's in connection with our mentioning the community volunteers. Jennifer, can you unmute yourself, Jennifer Medley?
Yes, that was what I was referring to. I should have been more clear in my in my comment, but yes. What it sounded like, partnering with the community health workers to around to make.
And Jennifer, you've made an important point. Certainly there are trained community health workers out in our communities, but there are also a cadre of people who don't want to do this all the time, but they may want to help out on a situational basis. And so they just need some basic information that they can use to be able to help, to provide support to someone else, or to teach someone how to use the resources in their community on a one-time basis. So I think we need to take advantage of all the different sets of skill sets out there and interest levels out there in our communities in order to be able to address this issue.
Okay, that's a great point. Yeah, I appreciate that.
But thank you so much for bringing up community health workers. Are there any other comments or suggestions or thoughts on improving birth supports to women during pregnancy?
I'll put a question out there. What do people need? I mean, I think this is an informed audience, and sometimes, the limitations of, from my perspective, I may read or see the same thing again and again because it's what I know and do. So, I think the goal is to improve outcomes, however that may be. And I did not have the benefit of sitting in on the conversations earlier today. So
we had some rich conversations. I wish you had been a part of it. I understand.
I was doing telemedicine visits. So.
I understand. I understand. That's important too. I'll start this, and in my experience, women want to be heard. Mm-hmm. And particularly Black women feel often unheard in not only just birthing spaces, but in getting into the health spaces, period. And so they want to be assured that when they complain about a pain or a difficulty, that it's recognized and believed, instead of sort of putting them off or treating them less than human, or not respecting their humanity in these spaces. I think that's very, very important. And that's one reason I think why promoting birth workers, and particularly doulas, in those spaces with them to additional support, so they can be sort of the eyes and ears for women in those spaces, becomes extremely important as we address this. This often makes me think about what we used to have in African-American communities back when the old granny midwives were practicing. Even though they may not have had the greatest medical skills because they weren't medical providers, they did provide a lot of social support, and they had cultural knowledge about women that I think made some differences in terms of how they perceived their experience in the birth rooms.
Right. I agree. I think that experience, with your healthcare provider, with your physician, midwife, in many cases, it may be a nurse practitioner who's involved in sometimes the disjointed nature of how practices are now, where we are frequently in a group practice, and the person who is the person at delivery may in fact not be the person that you've seen through the duration of your prenatal care. I think all of these things lend to potential for breakdowns in communication and breakdowns in understanding. But I think that's sort of definitely back to the point of having that advocate there throughout the visit, and being able to make sure that it sounds cold and callous, but being a healthcare consumer, okay? How can we be an effective consumer? So I think all of these things are important that can tip the balance sometimes one way or the other in terms of how effective someone is actually heard and how effective someone actually responds. And we would want, obviously, great outcomes for everyone. We would want bias never to creep in, but unfortunately, I do believe it does, and I believe it does happen. We need to perpetually work to remove those barriers to good care.
Any other questions, comments?
Great presentation, Dr. Greenfield. I agree with Dr. Harris. The women that we talk to, they want to be heard, but they also want their partners or mates to be acknowledged. They talk about how their fathers are never acknowledged, or they're asked questions about the fathers when they are absent from a visit, and so they want them acknowledged. Also, we had a mother talk about how her baby was in the NICU, and she had to advocate for the father to see the baby in her absence. Mm-hmm. And so I think that just noticing the amount of stress and responsibility on the woman during the pregnancy, and then also postpartum, because if you are stressed because your baby's in the NICU and you had, a difficult delivery, then you are also trying to advocate for the father to see the baby in the NICU. And I think that women also want to know who they can see. So I've had several women ask me, is there a list of physicians that care for, that have been doing a great job at caring for Black women? Like, is there a list of Black physicians in the state? Is there a list of physicians that anyone can recommend? And that doesn't exist, right? Because we don't grade physicians. But we should begin to at least acknowledge the physicians that are doing a great job with these women, so that they can trust that they can seek care in the hospital setting.
I mean, I totally agree. Trust is essential. Trust is essential throughout the entire visit. One of the things that, there is definitely a shortage underrepresented minority physicians. That certainly has been the case. I would say in the case of African-American physicians, that number has been hovering at about 3% since the 1970s, and it doesn't move. You know, and it's not to say that someone, if there is a difference in race or ethnicity between healthcare provider and between the patient, does that mean that inherently that there will be a problem or a discord between the care? I think that potential certainly is there when there may not be a shared background. However, those things can certainly be overcome. And I will say that patients and physicians need to, physicians particularly, the healthcare providers particularly, we need to learn how to address it. I'm glad to say that efforts are certainly being made in terms of implicit bias training, because I think these things actually, they do creep into behavior. They will creep into sort of subtle components in terms of how we listen, how we act. I think all of those things can adversely affect care. And so I'm really glad that you mentioned that, because that again, another opportunity to improve the support for our patients.
Well, I'm aware that there are many different implicit bias type trainings that are available to health professionals. One in particular that has struck me appreciably is the Speak Up for Black Women module, which is emphasis in the acronym SPEAK UP, SPAKUP, stands for different aspects of how a person can address bias that they're experiencing or someone has been exposed to in the healthcare environment, so that they become better advocates for their patients who are women of color. So Speak Up is one of the many things that I think are available. Someone is asking a question. I'd like to know how to express the importance of birth spacing without seeming intrusive to a parent.
Well, I think with any of the, these are crucial conversations. And I think a lot of this starts out with doing the best that you can to establish rapport and trust early on. One thing that is particularly relevant to women's health, and I will say this as a Black man practicing obstetrics and gynecology in the Southern practice, which is where I've been my entire career. I certainly know that it is important for me to begin to establish trust, and very, very quickly. And sometimes bringing levity to the conversation as appropriate, I have found to be useful, because I would say that, let's say I would say, Ms. Phillips, I totally recognize that we have just met, but I'm going to be very direct in terms of the conversation that we have, and certainly the intrusive nature, while it may seem that way, I've certainly found that patients quite often appreciate very direct talk, and that learning how to get to these conversations in a very direct, non-squeamish way is very important, because when we mention the issue of birth spacing, number one, ideally, we want to get to that 12, 18 months beyond one delivery to the other, so one, that the body has an opportunity to recover, so that the physiologic anemia that someone may have experienced is resolved. One, and then I don't think we can discount the impact on the psychological impact of having two kids at a very, very narrow interval. It's going to be financially challenging. It is going to be mentally and physically devastating, potentially as well. And I speak to this, and I will say, as I mentioned, I've been practicing for a while, but I'm a father of twins, one of which is a NICU graduate and spent time at Children's Hospital shortly after delivery. And I can tell you that I know the emotional toll that can take on someone. So all of these things are very important. So in fact, you said without seeming intrusive, I think, you know what, sometimes you may have to be intrusive, but respectful is going to be, I think, at the heart of it.
Well, I certainly think that it's important for a woman to believe and feel that you're making recommendations to her based on what's in her better interest. And so I think approaching it from the perspective of how it's physically advantageous to her to space her children, and also advantageous to her children in terms of her being able to give them the amount of time and attention that they need in order to be able to start that early development in a really positive manner. But I think it's also important for us to, again, recognize that the partners of the women also have a say-so in this process, and it's important to engage them in those conversations as well. And that's something I think we certainly need to do a lot more of in terms of involving the male partners in these discussions.
I mean, I totally agree. I can certainly recall one of the conversations that stands out with me. And it was a husband who said that was the most disempowering experience that he had ever had in his life, because he was used to being the guy to fix stuff. There's a problem, I come in, I try to fix it. And it was in a strange environment with a strange language, with people talking around him and not to him. And he just felt totally disempowered. And I think that part, have that conversation with the provider. Encourage folks to have that conversation with the provider from the very beginning. Because I certainly would say, I cannot think of a colleague of mine who would not welcome the opportunity to engage and have those conversations.
Well, it's almost 3:15, and so we want to respect everyone's time. Thank you so much, Dr. Greenfield, for being able to join us today and for sharing your experience and your knowledge. We certainly want to thank everyone for attending today's symposium. Just a reminder, as Dr. Bryant mentioned earlier, that within 4 to 6 weeks, if you have pre-registered for conference and you're one of the first 100, that you will receive a swag bag in the mail. And we just want to continue these kinds of conversations and continue this type of work toward improving the health outcomes in the birthing communities in Arkansas and in the United States. Thank you all so much for joining us today. And thank you again, Dr. Greenfield.